Hi friends, so you have given that CBoT exam and now I am here to discuss up live with you the microbiology questions. The questions were like moderate in difficulty and I suppose you must have done wonderfully well in this particular one. Fine. So let's start up with the first question of it. Okay. Hi Dr. Anil, good evening. So guys, we'll be focusing up of important points which are beyond this, we can discuss of. We'll discuss all those particular points very well and obviously in a very fast paced manner so that it should not be so lengthy and all. Okay. So yes, please try to tell up what you have marked up answer and we can talk about that also. A 10th class student came to your clinic with a pruritic rash as shown in the image. Here, you can see the region of it. You notice that the rash does not have any central clearing. So this is very clear that there is no central clearing in this particular one. What could be the possible organism causing this rash? Yes, what you have marked up? Abhinav, good evening. Yeah, what you have marked up in this particular question? Can you tell? Yes. Yes guys, what you have marked up? Dr. S have told it's Tinea cruris and very rightly that is being said that it is Tinea cruris. Okay, and the hint are obviously you can see up the groin region. This particular one is there in this particular side, that is the loin region, or also termed as dhobi itch. This particular thing is also termed as dhobi itch or jock itch. Fine, dhobi itch or jock itch. Very right, Dr. Anil, very right. B is the answer. Dhobi itch and jock itch. Important for you to remember for the exam is that this is being done by which particular organism? And the answer to that question is Epidermophyton floccusum. This name you need to remember. And another name along with that is Trichophyton rubrum. Okay? Trichophyton rubrum. So one name is Epidermophyton floccusum and one name is Trichophyton rubrum. They are the one which does this Tinea cruris. And here only I like to tell you, these two only does Tinea pedis also, which is also termed as athlete's foot. So Tinea pedis is also being done by this and Tinea cruris is also being done by this Trichophyton rubrum and Epidermophyton floccusum. Okay. Another important question which can definitely come in your exam is that this rubrum is having a colored pigment. So they can ask you in the dermatophytes which particular fungus have a red color pigment. So answer to this particular question is Trichophyton rubrum. Is it fine? So answer to this obviously now is Tinea cruris. Okay. Now coming to the other options, Tinea corporis, which is actually on the trunk region, mostly the lesions and all happens up. Okay. So you say non-hairy regions of the body are involved in Tinea corporis and all. In that you can see the central clearing. Okay, central clearing is observed in Tinea corporis. Okay, and this you already know, Tinea versicolor or also known as Pityriasis versicolor, done by Malassezia furfur. It is not furfur, furfur. And obviously another name you also need to know, that is globosa, not samosa, globosa. Okay, so this also is there. Malassezia furfur is also there. They are the ones, the causative organism. If somebody asks you which is more, so globosa you have to mark up. Okay, and the question of last FMGE exam was only that when you have taken the scales of it and you put 10% KOH, what you get guys? Spaghetti and meatball appearance. So that is also very clear to you. Now the next question can come is that which type of culture growth happens to be on this. So culture growth on this looks like a fried egg colonies, like of mycoplasma. Here also the fried egg colonies, they happens to be on the SDA. Is it fine? Now, talking about the Sporothrix skinky. Okay, this particular one leads to sporotrichosis, and as you already know that sporotrichosis is a dimorphic fungal disease. Okay, also termed as Rose Gardner's disease. And how does it spread off? Lymphocutaneous spread is the most common up, and it is having a pattern that is termed as sporotrichoid pattern. Okay, and dimorphic means it will be a yeast at 37 and it will be a, yes, it will be a East at 37, and it will be having the hyphal form at the 25. This is what is the meaning of dimorphic fungus. Okay. So very right, Dr. Anil, you have told wonderfully. Tinea corporis, superficial fungal infection, hand, feet and scalp. Yeah, Yogi, very good. History of Gardner in the sporotrichosis, Rose Gardner. Or another history also you can get in that. That is that somebody is traveling up in the Himalayas. Okay, so that can also be there in the history of it. That somebody is traveling up in the Himalayas and there that fellow get a prick. And after that, the lesion happens to be in a form of nodules, and that too in a pattern. That is a linear pattern, and that is what is termed as sporotrichoid pattern. And the drug of choice is itraconazole. Is it fine, guys? So coming to the next question here. The next question is, which of the following is not true for meningococci? Fine. Which of the following is not true for the meningococci? Yes, please. Anybody wants to tell up this particular question? Which of the following is not true for meningococci? Yes, please. In the chat box, you can tell up that which of the following is not true for this. Yes, meningo. Yeah, I'm waiting for your response. Which of the following is not true for this Neisseria? Yes, please. Anybody in the chat box? Tell up. Yeah, answer I've got is D from Abhinav, and very right, it is not sexually perinatally transmitted. Everybody knows that. And obviously it have a capsule, and it comes in our mnemonic also, Pachiavi MCV, or the capsulated organisms. It causes meningococcemia with petechial hemorrhages and gangrene of the toes sometimes. Okay. Important is that this is the complication of meningococcal meningitis. Okay. This is a complication which is associated with meningococcal meningitis. That is meningococcemia with petechial hemorrhages. Okay. And this you will get in the integrated fashion in the next. And they will be asking you after this that these types of features of petechial lesions and all, they can show you on the legs and all, and they can ask up, it is done by a gram-negative cocci, gram-negative bacilli, gram-positive bacilli, okay, or gram-positive cocci. Like that, the questions will be coming up in your next pattern, or any sort of a pattern is. And in this exam also, this can come in this fashion. Other things, that is it intracellular, extracellular, catalase positive, oxidase positive. So these all things you need to remember upon. Okay. And everybody knows that microbiology contributes around 40 questions. If directly we talk about it, it's hardly 15 to 16. But it integrates up with the PSM, integrates with the medicine and all. So, in fact, surgery. So everywhere we have this particular thing, and it goes up to 35 to 40 questions for sure. So it's negative gram. Yes, very right. It's a gram negative cocci, the meningococci, and it is having a capsule. And obviously it is diagnosed by the culture based methods also, and the PCR. PCR is a rapid method, you know, and culture is being done on which media, guys? Chocolate agar. And that's modified chocolate agar name is what? Thayer-Martin media. What you call that particular media name? Thayer-Martin media. And what is Thayer-Martin media? Thayer-Martin media is actually chocolate agar with antibiotics. Okay, that is actually the chocolate agar with antibiotics. And you are right, Dr. Anil, that it is positive for catalase also. And what you have written up in the comment section, that is for the oxidase stuff. So this particular organism, this already have come in the INICT exam. That what are the properties which you need to remember regarding this? Catalase and oxidase both positive. Which one? This particular meningococci. Another one, how does it looks like? It looks like a lens. It's lens-like, fine, and it is capsulated. Another important one which can be added to this particular point is it ferments glucose and maltose, both the sugars. This particular test sounds very like simple test, but it clearly differentiates between meningo and gono on the basis of this fermentation. Also termed as RCUT, rapid carbohydrate utilization test. Very right, Abhinav. It is both catalase and oxidase positive, and Dr. Anil have told up regarding this particular stuff that enzyme cytochrome oxidase, that particular thing is involved up in this oxidase test itself. Okay. So that also you need to remember. Now, coming to the third question here, a 6 weeks old infant presents to the pediatric clinic with paroxysmal coughing spells. So this is characteristic itself only, paroxysmal, okay, in a particular continuous flow, that is termed as paroxysmal coughing spells, post-tussive vomiting, characteristic of which disease, guys? Okay, inspiratory whoop. It is sufficient hint that we are talking about what? Whooping cough. And whooping cough is done by which organism? Bordetella pertussis. Okay, so this whooping cough, you already know, is also termed as whooping cough, as the name suggests. Other names of the same thing is what, guys? It is also termed as barking dog cough. Okay, it is also termed as barking dog cough because it feels like a dog is barking. Okay, so Bordetella pertussis leads to pertussis, also termed as whooping cough. Why whooping cough? Because whoops are present in that, and whoops actually come in which stages of it, guys? Let me tell you, let me give you the options: catarrhal, paroxysmal, or convulsant. So obviously it is coming in the paroxysmal phase. These particular whoops, high inspiratory strident sounds, they are observed in the paroxysmal phase. Okay, so catarrhal is the phase which we tell regarding it. This catarrhal is the phase which is the most infectious. Okay, this catarrhal is the most infectious. Okay, the paroxysmal, this particular phase, if we are talking about this paroxysmal phase, is that particular phase in which the real whoops they come. That is the high inspiratory sounds which we talk about in this. Other than that, what we need to talk about here is, other than this particular whoops, we need to know that this is the one in which even post-tussive vomiting can happen. Okay, post-tussive vomiting can happen, and if this particular thing that so much of coughing, if happens in a child, it is being said that even the ribs can break off. Okay, even the ribs can break off in this particular one, and that is what is termed as paroxysmal phase. And then the convulsant phase, that is the recovery phase. And the question which have come recently in your FMG exam only, that what is the drug of choice for the pertussis in children? And answer to that question is azithromycin, guys. And it can be repeated for sure in an integrated fashion with the microbiology. Okay, it can be repeated in the integrated fashion, that which drug you use in the children for this particular one. Otherwise, as such also drug of choice is what? Macrolides. What is the drug of choice? Macrolides here. Is it fine, guys? And yes, Dr. Anil, very right. The culture media, if somebody asks you, that culture media name comes from the name itself of Bordet, and the name is Bordet Ganju media. This is what is the name. And on this particular Bordet Ganju media, there is a thumbprint appearance which comes off. Okay, on this what comes? Thumbprint appearance, and this thumbprint appearance also termed as like bisected pearl appearance. Okay, bisected pearl appearance. And if we talk about the bisected pearl appearance, can you tell me, guys, that what is the drug of this particular bisected pearl is here? What about the string of pearls? String of pearls is observed in Bacillus anthracis. Okay, it is seen in what? It is seen in Bacillus anthracis. Fine. So let's go to the next question now. Which toxin is produced by EPEC? Okay, a very, very important and potent topic from which number of questions can come and will come in future also. Okay, and that is this. Which toxin is produced by EPEC? That is enteropathogenic E. coli. And answer to this question is, it is not the heat labile one, it is not the heat stable one, it is not the Shiga toxin. Answer is, there is no toxin released by the enteropathogenic E. coli. Okay, so you can also tell up that what you have marked up for the fourth one, that is it heat labile, is it heat stable, is it Shiga, is it no toxin? So Manan, the answer, yeah, very right, Abhinav, you are, I suppose, still on the previous one, slightly delayed is the live streaming. Yeah, very right, wonderful. So which toxin is produced by EPEC? The answer of ours is no toxin. Okay, what about these heat labile and heat stable one? So guys, these are secreted by ETEC. This particular enterotoxigenic E. coli, this secretes up heat labile and heat stable enterotoxin. Heat stable, we already know that what is the mechanism of it? Increased cyclic GMP. And heat labile is increased cyclic AMP. That is adenosine monophosphate. Heat stable is guanosine monophosphate. How to remember of? Stable. In stable, what resides? Ghoda. Ghoda, what you call? Where it resides? Horse in the stable. So like that you need to know. Yeah, Abhinav, very right. EPEC, this particular enteropathogenic E. coli is commonly affecting of the pediatric age group. This everybody knows. Pediatric age group diarrhea is being done by this fellow. Okay. So one thing is this. Another is it associates with A/E lesions. This particular one associates with A/E lesions. And what is A/E? Attaching and effacing lesions. Attaching and effacing lesions. What is the meaning of this? Basically, this particular EPEC, what does it do? It attaches to the intestinal villi and damages them. It effaces them. Okay, so that is what is being done. Because of this pediatric age group diarrhea happens. Okay, so you must be finding of cup-like pedestals and all that in this particular one. And the guys which you are telling, na, Dr. Anil, hemolytic uremic syndrome and fetal infants, in this particular thing is done by EHEC, not EPEC. Okay, that is being done by what? EHEC, enterohemorrhagic E. coli. That secretes Shiga-like toxin. Okay, SLT, that secretes up Shiga-like toxin. So guys, that was asked last time. Okay, that was asked last time. Cortex, I think both can be used, like cyclic AMP and GMP, both are the options. And GMP you can very well remember, G is Ghoda, Ghodai resides where? In the stable. So another one is automatically what? Cyclic AMP one. Okay, and this particular one, EHEC, if we talk about, in that this name, O157H7, this particular name, it associates with what, guys? It associates with HUS, hemolytic uremic syndrome, where? In the children, and in the adults it associates with hemorrhagic colitis. So this everybody knows. Fine. Yeah, very right, Abhinav. Enterocyte effacement with a cup-like pedestals. If these are there in your language of the question, they are talking about enteropathogenic E. coli. And along with that, for added information of yours, in the EHEC also we observed A/E lesions, which we are talking about. So remember this is the added point, that in this also you got to see up A/E lesions, EHEC. Fine. So they can give you a history that of a child having this hemolytic anemias, uremia features and all that, and they can ask which particular organism is responsible for it, because after the diarrheal episode it happened. So this O157, O means somatic antigen, H means the flagellar antigen. This serogroup is responsible for this HUS and HC. Okay, so that you need to know. Very right, Abhinav. The toxin which is released by this fellow is virocytotoxin. Okay, virocytotoxins, also in short you can call it as virotoxins 1 and 2. So virotoxin 1 and 2 is the one which leads to this particular EHEC. Now the question arises up that what is the culture media on which you will love to grow this? And the culture media, guys, you know, is SMAC. Okay, and SMAC is what? Sorbitol McConkey agar. Now the question comes, why we use it? We use it because this particular sorbitol McConkey agar, the sorbitol is not fermented by EHEC. Otherwise, every E. coli ferments it, and that's why we get to this particular one. Yes, Zeba, very right. It's an outbreak of bloody diarrhea happening up because of EHEC, and the culture media is a asked question. Again, it can come, and the next question can be that which other thing we can use other than the SMAC. SMAC stands for sorbitol McConkey agar. Intentionally we use it because it is not fermenting the sorbitol, and other one which we can use is rainbow agar. Okay, other one which can be used is rainbow agar, and entero-invasive E. coli is also there, which resembles shigellosis, and that also secrete up Shiga toxin. Fine, and there is a test positive in that, Sereni test, that you already know. And EAEC, that particular aggregative one, it causes persistent type of diarrhea. So this is also there. And important, which can be asked other thing, that which two out of these can leads to traveler's diarrhea. Okay, which particular out of these E. coli related with traveler's diarrhea, and no guessing in that, you already know the most common cause of that is ETEC, and the other one is EAEC. EAEC is aggregative E. coli, ETEC is toxigenic E. coli. So T for T, that's very good. Abhinav, very good. Rainbow agar and SMAC you already told up. Wonderful. Okay. Wonderful, wonderful. So all these are very high yield ones. Question definitely will be coming from this. And what I have seen up, those persons who does micro well in the last 1 or 2 years, what I have observed up, those who lands up in 140, 142, 144, and the history which I've taken off of them, they mostly have left out the microbiology, and when they do it, after that, their score either wins above 200 or it's like 165, 70. That particular thing comes, and I'm telling it by experience that you can't leave even forensic or any other thing unattempted. You should not go in the exam like by leaving of some subjects, because you don't know that where you are lying off. 148, 149 really pinches. So remember, you have to cover up everything in a smart way, obviously. It is not like you will get after it and you want to become a microbiologist only. No. In a smart way, you have to handle other things. Fine? Now, the next question. Which of the following is this characteristic lesion caused by Borrelia burgdorferi? So it's a very straightforward question. You must have answered it well also. Can you tell me up, guys, that which is the characteristic lesion caused by Borrelia burgdorferi? Yeah. Yeah, please tell. This particular one I'm waiting up. That what is this characteristic lesion caused by Borrelia burgdorferi? Yeah, tell. Is it erythema nodosum? Is it erythema multiforme? Is it erythema migrans? Is it erythema marginatum? The answer is very right, erythema migrans. Okay, bullseye lesion, very right, bullseye lesion. And first of all, we need to remember certain points regarding it, that this particular one looks like a target lesion or bullseye lesion. And this particular disease, what we are talking about is Lyme's disease. We are talking about which particular disease, guys? We are talking about Lyme's disease, which is being transmitted by what? Tick. Okay, which is being transmitted by what? A tick. Erythema migrans, very right, wonderfully told by everybody. Achha, you are confused in that. So don't be confused up by seeing this name. You should not be confused. We are talking about Lyme's disease, which is not there in India for sure. Okay, it's an American disease, but still a number of questions they are asked regarding it, and one of the questions surely will be this. You are getting up this target lesion or bullseye lesion. They can show you this picture. They can ask which is a transmitter. Transmitter is a tick. That you know. Okay, and we have made a wonderful tick also for this, that somebody have brought a burger at your door. Okay, and in the lieu of that burger at your door, that is burgdorferi, a tick comes and bites you and lands you with which disease? Lyme's disease. Then the children, the students only, they have improvised this, and they said, sir, along with the burger, they have brought the lime water also. So you can include up this Lyme's disease. Then the important features regarding Lyme's disease, a very important one. So remember, guys, this is the disease in which myocarditis happens. Okay, along with the myocarditis, there is blocks. Okay, first degree, second degree heart blocks are seen in this particular one, and even you have meningoencephalitis. Even you have what, guys, in this? Meningoencephalitis. So remember all these particular important ones. Yeah, very right, Unisol Gaming, you have told wonderfully. The marginatum is observed in RHD. Nodosum can be seen in SLE. Yeah, and number of drugs can also induce up the nodosum stuff, erythema nodosum. But I want to tell you some extra points regarding the Lyme's disease, and that is myocarditis, heart blocks, meningoencephalitis. These are the important ones, and drug of choice they can also ask of, and drug of choice also revolves around doxy. And if they ask you that what is the culture media used for this particular thing, the culture media for Borrelia burgdorferi is BSK, and BSK stands for Borbor Stonor Kelly. And remember, this is not a Bengali name. Borbor Stonor Kelly, or in short form, Kelly's media. Yeah. Post-Lyme syndrome, you have fatigue and all. So that is also important. In post-Lyme syndrome, you have fatigue and all. And important is, which I am telling of, that this is the only disease in which you observe heart blocks and all. Which other disease you observe heart blocks? So this is the only disease, and this they will catch upon and they will ask in the exam. So this is what is the mindset of the exam. Certain things which are peculiar to a particular disease, they will ask you. Last time I've told up that in the NEET PG I've told up that they will be asking you that conjunctival suffusion, not effusion I'm telling up. Conjunctival suffusion is observed in. So conjunctival suffusion is observed in, guys, leptospirosis. And that I've told up and that was there in the exam. Okay. So remember here also the Kelly's media, ceftriaxone we can use, doxycycline we can use regarding this particular one. Okay. Because it is having number of phases. One of them we can use doxy, and in some of them we can use up this ceftriaxone also. Okay. Now coming to this one. All are preformed toxins except. Okay. All are preformed toxins except. So the first one is Staphylococcus aureus exotoxin. Yes, it's a preformed one. Emetic toxin of Bacillus cereus, Chinese fried rice one. Yes. Clostridium botulinum toxin, that is the canned food one. And Vibrio cholerae toxin. These are the options. What's your answer for this particular question? First of all, let me have the answer from you. What are the answers of this particular one? You can, INICT, actually the knowledge will always help. So Cortex user, you can use INICT PYQs also, at least some facts of it. Okay, at least some facts of it that you can be remembered. Otherwise, it's better to go for the NEET PG, and that PYQs are also more than sufficient if you want. So answer is being given as D. And very right, guys, the answer is D. Okay, the answer is D. This is not a preformed toxin. Which one? Vibrio cholerae is not a preformed toxin. And Staphylococcus aureus exotoxin is a preformed one that associates with the food poisoning. Even the Staphylococcus skin scalded syndrome is also being done. Emetic toxin of Bacillus cereus, it mimics off in the incubation period, that is over 1 to 6 hours. That also new. And whenever you see this name, what should come in your mind? Chinese fried rice. That also you know. Okay. Clostridium botulinum, one important thing, guys. First thing is this toxin can work on any of the junctions. Okay. And important is it is having anticholinergic action. This question will come. This have already come in the NEET PG. That it is having an anticholinergic action, and anticholinergic action, you need to know that anticholinergic action is there on various junctions. And this particular fellow, Clostridium botulinum, associates with what? It associates with constipation. This is the one which associates with constipation, and the canned food poisoning is statistically being done by this particular Clostridium botulinum. Okay. So I suppose you have got the answer. The answer is Vibrio cholerae 1. Another thing important regarding it is having A and B components. B helps in binding, and binding to what? This was the INICT and NEET PG question, that is GM1 ganglioside receptors. GM1 ganglioside receptors, and this was asked that where does it attach. Another is ADP ribosylation happens up of which particular protein? Of G stimulatory protein. So guys, this question can come that which particular protein is involved up in this. The answer is G stimulatory protein is involved up in the ADP ribosylation. Okay. Abin Salem pre-synaptic, I've told now this can be at any of the junctions. Yes, there is a history of honey use in the children. Yes, that is there. Very right. Okay. So answer to this particular question, guys, is obviously what? Vibrio cholerae toxin. And this particular Vibrio cholerae acts on which junctions? That also a favorite question of FMG. That is zona-occludens or tight junctions. Okay, they are the same thing. That also needs to know. Now coming to this, which mechanism of genetic transfer is responsible for the acquisition of a new trait by a recipient strain in the bacteria? So this particular question is like a slight bit, what do you say, is a twisted one. The answer to this, a better answer to this can be others also, transformation. Okay, so transformation is actually what? That through the agency of free DNA, a new trait is being taken up by the recipient strain of the bacteria. Okay, but you can argue on that happens in conjugation also, that happens in transduction also. So that's why I'm saying up. This is not a like complete question up, and what you have marked up, it's up to you. Okay. So answer to this question actually is all the above. That is transformation also it can be, conjugation it can be, and transduction also it can be. But overall, if we see up that which is generally responsible for the acquisition of a new trait, actually that is acquisition is by the conjugation tube also. So that is also one of the things. Transduction is through the bacteriophage mediated one. So in that also you can go for the recipient strain, new particular thing. So this is a sort of what you say, a controversial one. I can take up all the three as answers, but better answer obviously through the agency of free DNA this thing happens in the transformation, and that was demonstrated by whom? Griffith in the famous experiment done on the mice with the help of rough strains of pneumococcus and the smooth strains of pneumococcus that you already know. Okay. So this is there. Conjugation, we have a conjugation tube and there is a transfer through the conjugation tube, and this is what is the most important method by which the resistance transfer happens in the bacteria. But in some of the bacteria, it happens due to transduction, like in the Staph aureus. Okay, transduction, wherever this word comes, immediately what should come in your mind? That is the bacteriophage mediated. And bacteriophage is what? Bacteriophage is a virus, guys. Bacteriophage is a virus. So that also you need to know that it's a virus which eats at the bacteria, and along with eating, it gives up some traits to this. So it is of two types, lysogenic and lytic. In lysogenic, they form a hybrid with the parent bacteria, they form a hybrid that is termed as lysogeny. And lytic one, when they take the control of that particular cell. And if I ask you that lysogenic conversion happens in which particular bacteria? So that is Condivectin diphtheria. If we say na, that every CD is not pathogenic, it is made pathogenic by beta-phage tox gene, and this conversion is termed as what? This conversion is termed as lysogenic conversion. So I hope you get the answer. All of them can be the answer, but yes, the better one will go towards the transformation. Okay. Now, which of the following is not true for the cell surface proteins? CD56 is a marker for macrophage. This itself is wrong. The answer of ours is A itself. CD56 and CD16, they are the markers for natural killer cells. Okay, and we have learned them in the videos also like this. Ab tak chappan means that particular movie was coming. So CD16 and CD56, they are the ones which are the CD markers of natural killer cells. Okay, and natural killer cells is a part of innate immunity or acquired immunity. This also have come. So answer to that particular question, guys, is innate immunity. They're the part of innate immunity. Okay, and that we already know. Na? Acquired immunity, hardly four things comes: B cells, T cells, antigen presenting cells, and classical complement pathway. And rest of all things are part of what? Innate immunity. In that also what comes? Natural killer cells. Okay. If we talk about the second option, CD34, this can also come in your exam. This is a hematopoietic stem cell marker. This is the hematopoietic stem cell marker. CD4 and CD25, they are the markers for regulatory T cells. This also is important. And CD16, which is a natural killer cell marker, binds to the FC portion of IgG. And if you remember up, this mechanism happens to be in the cytotoxic hypersensitivity. That is type 2. Okay, type 2. So this, I suppose now it's clear to you that the answer to this question obviously is the A. CD56 is a marker of natural killer cells, not the macrophage. CD34 can come as an answer, like a question. Hematopoietic stem cell marker is which one? CD34. CD4 and CD25 already asked INI-CD question. They are the markers of regulatory T cells, and CD16 binds to what? FC portion of IgG. And this is one of the mechanisms in the case of type 2 hypersensitivity. Is it fine, guys? Nobody have answered this question up till? Difficult one, kya? It's not a difficult one. So 2-3 questions I have told up regarding it, that this is a innate immunity stuff. Now you have like told A, Anil. Okay, coming to the next one. The patient with a history of traveling to Ohio. Okay, not Ohio, Ohio. Ohio is a place where in the USA. And it shows the following culture smear characteristic with lactophenol cotton blue. So first thing important, guys, is this, that lactophenol cotton blue name, whenever it comes, immediately what should come in your mind? A fungus. Okay, so we are talking about a fungus, and important is that if we talk about a fungus of this way, and OU USA name comes, so अच्छा कॉर्टेक्स इज टेलिंग टाइम ही नहीं मिला आंसरिंग का. ओके हाँ तो ये बता दो यार, ये बता दो इसका आंसर क्या है. तो फंगस हो गया. That particular thing have a traveling history to OEO, USA. So this is endemic. So you can say that this is a sort of what? This is a sort of endemic mycosis. Okay, it is like in a particular regions only. And we are talking about which disease, guys? Histoplasmosis. So you have multiple hints in that, and what you're observing inside it, these things, they are termed as tuberculate macroconidia. This is termed as tuberculate macroconidia, and this is what? This is the mold form of it, because it is having a narrow base budding as the E cells. Okay, or your Darling's disease or histoplasmosis. Very right, guys, you are wonderful in that answering. Okay, and we are observing in this picture what? Tuberculate macroconidia. And what we can observe, which can come in your exam, is this thing, that in the bone marrow smear, guys, we have done the bone marrow biopsy, and from that you have made a smear. In that, what you can get? So guys, in that you can get narrow based budding E cell. What you can get in that? Narrow based budding E cell. Okay, so this also needs to be remembered. The narrow based budding E cells, they are observed in the bone marrow smear. This question can come. Another thing is chronic histoplasmosis. Chronic histoplasmosis mimics TB. How? That is, cavity formation is there. The cavity formation is there in TB also. So there was a question regarding cutaneous involvement also in histoplasmosis. There was like lesions all over the face, and they were of the nodule like a acne. So that thing also happens in cutaneous histoplasmosis. The number of questions can in and around form around it, and the main portal of entry is the spores are inhaled off. Okay. Okay. So Darling or Darling's disease, also termed, because it was discovered by Christian Darling, therefore termed as Darling's disease. And important thing is it's done by Histoplasma capsulatum, but does not have a capsule. This is also an important thing. Chitin and cellulose, there obviously the fungus will be having it now. So now talking about this, question number 10, that the patient presents with colicky pain and diarrhea. Okay, the patient presents with colicky pain and diarrhea. On history of fever and stool sample is given for investigation, and in that, this image which you are getting up, this is actually, they have wrongly made this one. So quadrinucleate cyst, they want to ask up in this, and the quadrinucleate cyst is statistically observed in Antamoeba histolytica. Okay, some quick points regarding Antamoeba histolytica. Antamoeba histolytica obviously leads to dysentery, amoebic dysentery. And amoebic dysentery, when these amoebas try to float up to the extraintestinal spaces, that is to the liver, they form a flower shape also. So that is one of the important things. Okay. Besides that, what is the infective form? Infective form is quadrinucleases, and this comes in the stool also. And the trophozoites. Trophozoid characteristic feature is engulfed RBCs. Okay. What are the names of the free-living amoebae? Naegleria fowleri, Acanthamoeba, Balamutia. Naegleria fowleri is also termed as brain-eating amoebae. Okay, that is also termed as what, guys? Brain-eating amoebae. So yes, very right, Apurva. Answer is B. And the future doctor also told, Shivendra also told, answer is B. Very right. Okay, and you can grow this on some culture medias like PCR, you can say, and Phillips, Craig's, and Robinson. Like that, you can remember them up. And important is that in the extraintestinal amoebasis, the most common site is posterior of right lobe, and it is posterior superior. Okay, that particular region in which you have Encovy sauce plus the chocolate plus because of the damage to the hepatocytes. That also is important. Okay. Now, which of the following is not true about the given image? So this is a pulp infection on the finger, so termed as phelon, and obviously you know that this is being done by Staph aureus. Okay, this particular infection is being done by this, that is a Staph aureus. And what are the other things which are being given in the option? Let's see them. May cause osteomyelitis. Yes, you know that Staph aureus is the most common cause of acute osteomyelitis, but important is that in the case of sickle cell anemic patients, it is Salmonella. This question is coming. Okay, they will give you a sickle cells, RBCs, and they will arrange it in this particular one. May be caused by a pinprick injury. Yeah, Definitely it can be. Constitutive organism is Staph epidermidis? No. Answer is Staph aureus. Okay, maybe treated initially antibiotic? Yes, it can be. So answer to this question is C. Epidermidis does what? Any sort of intervention if you talk about, that is IV drug abusers, okay, some shunting happened up, prosthetic valve endocarditis. So these all are done by what? This particular epidermidis, means any sort of intervention. And it is no biocin sensitive or resistant, guys. It is no biocin sensitive, okay. Whereas the Staph aureus is the most common cause in the IV drug abusers for the endocarditis. It is a common cause of native valve endocarditis, which is also termed as ABE. ABE means acute bacterial endocarditis. And these are the favorite questions of the examiner, which they ask upon again and again. Okay. So number of students have told wonderfully. The answer is C. Now coming to this. The investigation of choice for the diagnosis of pulmonary TB as per the RNTCP guidelines. Okay. So what is the answer of this question? Let me wait for your response in this particular one. What is the answer of yours? The first investigation of choice for the diagnosis of pulmonary TB as per the RNTCP guidelines. Yes, please. Can you tell me? What is the answer of yours? Yeah, very right, Anil. Felon, I've already told up. Yeah, in this, what is your answer, guys? Answer is B, C, A, D, what? So answer, as future doctor have told wonderfully, the answer is B. You should go for sputum smear examination as per the RNTCP algorithm. And in this, if it is smear positive, confirmation happens. If it is not, then go for the chest X-ray. And in the case of pediatric TB and all, you go for CBNAT. And in extrapulmonary TB also, you go for what? CBNAT. And what is CBNAT? Cartridge-based nucleic acid amplification test. Is it fine? And never give up also given the answer. That is B. Very right, guys. So answer is sputum smear examination. And on this, the confirmation happens. If it is not, then you have to go for chest X-ray if it's a suspected case. And CBNAT is there for the pediatric ones and extrapulmonary TB. Is it fine, guys? Now coming to this. 1.5-year-old child presents with one episode of wheezing and breathing difficulty. The chest X-ray is done. It shows bilateral hyperinflation. Okay. Which organism is most commonly responsible for that? So I will wait up for the response because as it is the last question here, so needs to wait up that what is your answer in that? Yes. Can you tell up that what is your answer in this last question of microbiology? A 1.5-year-old सी कब आएगा? सी आएगा भाई पीडियाट्रिक टीबी में और एक्स्ट्रा पल्मोनरी टीबी में. जब एक्स्ट्रा पल्मोनरी टीबी हो तो उसके लिए सी आएगा. हाँ, फ्यूचर डॉक्टर हैव आंसर्ड दिस ऑल्सो वेरी राइट. फ्यूचर डॉक्टर इस बार हो गए तुम पास. ठीक है. या वेरी गुड अपूर्वा. इट इज RSV. द आंसर टू दिस क्वेश्चन इज व्हाट? RSV, that is respiratory syncytial virus, and that you know that this is the picture of it. And it does in children acute bronchiolitis. It does what? Acute bronchiolitis. And the drug of choice is also a very asked question, ribavirin. That is what is the drug of choice. And interestingly, what they have done, like in the previous FMGE exam, they have asked up that does it have H, does it have N? And what is this H and N, guys? H is hemagglutinin, N is neuraminidase. Okay, H is hemagglutinin, N is neuraminidase. That you need to know. And both are absent. Guys, both are absent in this RSV. And it's a paramyxovidae family member. That you know. And these respiratory syncytial virus, why we call them as syncytial or syncytial ones? Because they produce multinucleated giant cells. Why? Because they have a fusion protein. Because of that fusion protein, they have this particular thing. And very right, Anil, ribavirin is the answer. And that's why we say that H and N also is important here to ask, because paramyxovidae family is having them. And this was the question, does it have? It does not have. Hemagglutinin and neuraminidase, they are the features of influenza virus, and even in the para-influenza they are present. In measles, N is absent, H is present. So this can be a future question for you. Okay, guys? So we will discuss up in one of the image-based sessions soon, some images also. And stay tuned up for the next discussion in this particular series of CBoT test discussion up. I hope you find this particular one wonderfully easy to understand and useful. So thank you so much. A very best of luck from my side. Stay tuned.
Hi students, welcome back to our recap session. In fact, not recap session, it's a discussion session of CBoT exam. And that was a wonderful previous session taken by Dr. Sonu. Now we move on to forensic medicine. Okay. In this session we had 10 questions and we are going to discuss them all one by one. And I can see there are many students who are present live with us right now, and although I would want everyone to be addressed personally, but for the sake or the brevity of time, let me welcome you collectively. So welcome to the session, and let's begin this session by taking up question number 1 itself. So question number 1, which of the following is true about rigor mortis, right? So, if you will see, the essence of this question is that it has come up from an area of forensic medicine, which is essentially very important, the post-mortem changes. Okay. So, every exam tends to feature at least one question from that segment of forensic medicine itself. Okay. And then second is from the topic of post-mortem changes, rigor mortis is one of the most commonly talked about post-mortem change or post-mortem development, I should say. Although in examinations, the history of examinations, rigor mortis hasn't been asked in that frequency as we would have anticipated, but still it is a very, very important phenomena, right. So, let me see if how many of you answer this question. If none of you are going to go for answering the question correctly, then we will move on to the discussion itself. Waiting for I can see, yeah. So, we have got answers from Future, Manan, Pratik also, very welcome to you, Anil also, never give up, wonderful, wonderful name though. Right. So, if you will see this question, there are 4 options here. That the first option says it involves only a group of voluntary muscles. Now, from the knowledge of forensic medicine, we know there is something called as Nisten's rule. Okay, Nisten's rule, and Nisten's rule say that contrary to common belief, rigor mortis involves both voluntary and involuntary muscles. Okay. So, obviously first question is wrong. In fact, if we look at one of the one-liners, single liner answer question, that which muscle gets involved with rigor mortis at the earliest, we know that it is heart. Okay. It has first involvement of rigor mortis, right. So, first option is already wrong. Second option is it is dependent on nervous inhibition. This is wrong because it depends upon depletion of muscle ATP store. Third, it does not occur in a fetus less than 2 months or 2 months old. That is a correct choice because our literature says it is a process which is not seen below the viability of fetus. So, we are not expecting rigor mortis not seen before 7 months of intrauterine life. So, if there is a fetus who is less than 7 months, in the death of that fetus, rigor mortis is not expected to be seen. Okay. So, which of the following is true about rigor mortis? This is a statement which is true about rigor mortis. Muscle protein coagulation is the underlying mechanism. Many of you have answered this, but that is not the correct answer because we know that muscle protein coagulation is not the underlying mechanism in rigor mortis. It is rather a mechanism of pugilistic attitude, right. When we burn the body and the proteins of the muscle, they get coagulated due to heat if the temperatures are greater than 65 degrees centigrade and the muscles become rigid. Now, that is the mechanism of pugilistic attitude seen in burnt bodies. Okay. What is the mechanism of rigor mortis development? It is the depletion of ATP as a result of actin segments. They are interdigitating more into the myosin segment, right. Remember the physiology of sarcomere, calcium coming from sarcomere to maintain the contraction of the muscle. Now, that exactly is the mechanism of rigor mortis. As the ATP depletes, the interdigitation persists, and that is why rigor mortis develops. So, it has to do nothing with coagulation of muscles, right. Great. Surbi is saying I missed to see fetus. Surbi, I am just repeating it for you. It's written on the board itself that rigor mortis is not seen before 7 months of intrauterine life. So, what we are saying is that if there is an abortion done, we are not talking about the legality of the abortion. It could be an MTP, it may not be a criminal legal abortion, but if there is an intrauterine death, the age of the fetus is less than 7 months. After the expulsion of that fetus, rigor mortis is not expected to be seen. Okay, it is not seen before the viability of the fetus, but more than 7 months fetus does show rigor mortis. Okay, if they die. Right. Anil is saying silly mistake ho gayi. Yes, Anil, lot of times these kind of silly mistakes cost lot of numbers to us, and that is why it is very, very important that you read the question correctly. Particularly if in the question I would have written in the option number C itself that it does not occur in a fetus less than 7 months, probably most of you would have paid more attention to that line, right? But what I want to intend or what I want to say here is less than 2 months is less than 7 months itself. So, most of the time we read the impacting line so much that we kind of forget what is the real meaning of it. Okay, and yeah, that's why we recreate these tests for you, so that whatever silly mistakes we are making, we can rectify them on time. Let's go ahead with question number 2. What is the predominant skull type observed in the Indian population? It's a very age old question. It's not a difficult question. The answer is very, very simple. The answer is mesocephalic. Remember, mesocephalic is medium headed skull, right? And what is medium headed skull? It is the calculation of its cephalic index. So, when we say cephalic index, which is maximum breadth of skull divided by maximum length of skull into 100, there are 3 reference ranges. If the answer is 70, if the calculation comes between 70 to 75, it is dolichocephalic. The important race that we don't have to forget here is Negroes. Then 75 to 80%, it is Europeans or Caucasians, right, along with the Chinese population also. And then 80 to 85, it is Mongolian race predominantly, and Indian population also falls in the mesocephalic ranges. So, this is one bony calculation which is highly useful in determination of race. Okay. Apart from that, another important bony calculation that we need to remember, which is helpful in determination of race, क्या होती है वो? That is long bone ratios. Remember this and retain this. Apart from cephalic index, long bone ratios. Long bone ratios, there are 3 important long bone ratios. The result of their calculations helps in determination of race. One is crural index, that is index of the ratio of the long bone of lower limb, crural. Second is brachial index, and we all understand brachial has to do something with the upper limb. So, it is the ratio of the long bones of the upper limb. And third is intermembral index, right. Intermembranous index is the ratio of the long bones of the lower limb and upper limb. So, it is interlimb long bone ratio. So, whatever result that we get out of calculation of these ratios, it will be helpful in determination of race, not sex, not stature, not age. So, remember these two very important bony calculations, one is cephalic index and second long bone ratios favoring determination of race. Let us move ahead. Yeah, a lot of people have given correct answer in this question, at least because it is a very straightforward question, right. So, sometimes very straightforward questions do come, particularly in forensic medicine, and if we have read the subject well, we can score 100%, right, as we just saw in this example itself. Okay. Which of the following statement about laceration is true? Again, now I want to highlight here that all those who are studying for the exam, if we are preparing for an exam which includes the subject forensic medicine, right, injury is an area which you cannot leave, because that is the main day to day work, the bread and butter of forensic medicine. And in injury, if I say there are 3 blunt force injuries like abrasion, contusion and laceration, and then 3 sharp and pointed weapon injuries like incise wound, incise wound, stab wound and chop wound. So, we have 6 main injuries to talk about. One injury which is of utmost importance is laceration, is absolutely laceration, right. So, laceration is something about which we have to read everything, right. Great. So, the question is, which of the following statement about laceration is true? Okay. So, we need to pick up one correct answer, that is all, and most of you have given answer C, and first of all I would say yes, the correct answer is C itself. Let us see what exactly is laceration. It looks something like this. It is rupture of skin, right. What are the hallmarks of laceration? It has irregular margin and it has presence of tissue bridges. Okay. Presence of tissue bridges. Yeah, as Dr. Anil Soni also said correctly, it is a injury that is produced by tearing of the soft tissue along with the skin, right, absolutely correct. So, what are tissue bridges? In the depth of the laceration, we can see fibers which are connecting to both the margins. Okay. If not seen by naked eye, they can be seen by naked eye also. We can make use help of a magnifying lens, and then they can easily be identified. Now, when we talk about laceration, we understand that laceration is an injury which has been given by hitting of a blunt object on the body. So, consider a lathi or a danda or a bat or a stump or a rod hitting the body. What will happen to the skin or the area of the skin which has been impacted? One, it will rupture, right, that is called as laceration if the force of impact is really high. But because it is a blunt force which has been delivered to that area, we are expecting the underneath vessels to be crushed also, which means the margins of the lacerations, they are expected to be bruised also. So, if you will see the edges of lacerations are clean, it is not a correct option, because we have already seen that edges of lacerations are irregular, they are not clean. Clean means regular, right. Second, if you will see bruising is absent in laceration, it is also a wrong option, because when the blunt force is landing on that area, it is bound to bruise the area also. And if you see option number D, that is, it is caused by a sharp injury, we all know that is a wrong choice, right. Now, when we talk about, yeah, very good, a lot of people have, future doctor has said floor is crushed, irregular margin, yeah, there are all hallmarks of laceration. And in your preparation, if you are reading laceration, there are 5 different types of lacerations. They are stretch, tear, cut, avulsion and split. One laceration which is extremely important, read everything about it, is split laceration. Split laceration is a laceration which develops on the skin when the skin is pressed between two hard objects, and as the skin splits open because of that phenomena, the margins of the split are very regular. As a result, when you do a primary inspection of that lesion, it does not appear to be a typical laceration because of the regularity of margin. These are called as incise looking lacerated wounds. These are called as incise looking lacerated wound. This phenomena has been asked in exam multiple times and it keeps repeating because it is a very important phenomena, right. So, what did I say in the generation of split laceration is that the skin has to be pressed or crushed between two hard objects. So, where these lesions can develop? These lesions can develop at that point of body where there is a hard object already present underneath the skin, and that is bone. So, bone is in proximity with the skin. If you hit that area of the body on top with a blunt weapon, the splitting phenomena can happen. So, all the bony prominences of the body are the vulnerable area where split lacerations can generate if those areas are impacted by blunt weapon. For example, scalp, forehead, zygoma, chin, elbow, wrist, knuckles, knee joint, shin, malleolus, all the bony prominences of the body, right. So, these are the critical information around which questions are generally made. Let us move further, right. Abhinav have answered very correctly that it is bony landmarks, right. Everybody is contributing in writing something around split laceration. I am very happy that most of you, you understand the context of split laceration and you understand why it is important, because these kind of injuries that we are talking right now, they are very common in cases of assaults, and believe me, in daily practice there are so many assaults happening every day with blunt weapons, and when injury assessments are done, these injuries, the knowledge about these injuries is unparalleled. A doctor having a correct knowledge about split laceration will never draw up a bad MLC. Okay. Let us go to question number 4. It is a very straightforward question. The stem of the question is, the question has arisen from one of the questions which appeared in this year's NEET PG examination. If you recall, this year's NEET PG examination, a question had come regarding a child coming back from with his grandmother, and something had happened, and then there was a symptom of priapism also given in that child, right. So, from there this inspiration of question has come in, that cantharidin toxin is found in which of the following. So, the name of the toxin or the active principle that may be present in the extract is cantharidin. Where is it found? The answer is option number 1, Spanish fly. Spanish fly. The one very important thing that you need to remember about Spanish fly is causes priapism. Okay. It is a toxin, but one of its toxic effect is sustained erection also, priapism, right. So, looking from the question that had shown in the examination, in that question Spanish fly was not an option. I am talking about the question that showed up in this year's NEET PG examination. The answer was a scorpion bite. Okay. So, when we talk about priapism, one, remember Spanish fly, the active principle is cantharidin. Okay. Second, priapism can be seen by scorpion as well as spider envenomation also, right. So, taking the central priapism as the central symptom, So, what I have done is I have taken priapism as a central symptom in this question and created a question around it, so that now our viewers know that priapism can be produced by scorpion, it can be produced by spider, it can be produced by Spanish fly, right. Okay. Croton tiglium, Aberus picatorius and Ricinus cuminis, all of them are vegetable poison, okay. All of them are seeds. We talk about them in our classes. Let's move on right now. All are feature of postmortem appearances in case of antemortem hanging, except, again a very classical kind of a question, again a very classical kind of a question. One question again shows up from the chapter of asphyxia in our examination, and this is a very straightforward question, that what would not be seen in a case of hanging. La facie sympathic, will it be seen in face of hanging? The answer is yes. Protrusion of tongue, yes. Amisette sign, yes. Ligature mark always below the thyroid cartilage, no. So, what would not be seen is option number D. So, where do we see ligature mark? Of hanging, where do we see it? Okay, I am waiting for responses. All of you who are present online, can you give a response? Where do we normally see ligature mark of hanging? Okay. Where do we normally see it? What is the area of body where we see it? Great. Future Doctors 417 has given above thyroid cartilage. Yes, and that's the correct answer. The normal position of ligature mark of hanging to develop is above thyroid cartilage. And if we were to revise some other findings of ligature mark of hanging, then what would they be? Number 1, it is above thyroid cartilage. Number 2, it is generally horizontal or oblique? It is oblique, right? It is oblique. Third, in comparison to strangulation, the facial features, the congestion, the petechiae, are they more intense in hanging or ligation, or in ligature strangulation, or in any other form of strangulation? The answer is strangulation. So, more intense features are seen in strangulation. Okay. Then number 4, what happens to, what is the texture of the ligature mark? Hanging versus ligature strangulation. The ligature mark of hanging is dry and hard to touch. So, when you touch it, it feels dry and hard and has a parchmentized appearance, whereas ligature mark of strangulation is moist, it is not dry and hard. Okay. So, these are certain important characters that we keep on revising again and again in the class also. I am very hopeful that you also have read them, remember them also, that what goes in favor of hanging, what goes in favor of strangulation, these kind of things keeps on appearing in examination again and again. Right. Let us move to question number 6. A woman has sexual intercourse with her boss as he induces it for career progression. Okay. So, what is this line saying is that a woman has had sexual intercourse with her boss, and that boss has induced that sexual intercourse or induced that woman to have it with him in favor of her career progression, right. So, in this line, one thing should be clear to us while reading the question, that act is not forceful, the act is consensual, the female has agreed for it. Okay. Another employee reports it to authorities, the boss will be punished under which section? Okay. This question is highlighting a situation where the penalty of or the punishments of rape scenarios should be very clear to the students, right. Now, when I say penalty or punishments to rape scenarios, all students should know that when we talk about the concept of rape, the punishment of rape comes in 376 IPC, And then there are so many other scenarios of rape. 376A, 376AB, then we have 376D punishing for gang rape, then we have 376DA, and we have 376DB, and then we have 376E. In between we left 376B and C, because although 376B and C also punishes for acts of sexual offences, but they are not directly linked to a situation or a scenario of rape. 376B popularly is known as punishment for marital rape. Okay, we have read about it in papers again and again. Just for the sake of repeating, I'll quickly repeat it, that what is marital rape? That when a couple, that is a married couple, is living in separation under the order of a court, at that point of living in separation, the rights, the conjugal rights, the marital rights of the husband are suspended. What are the marital rights of the husband? To have sexual intercourse with his wife. So those rights are taken away while the couple is living separate. Okay, at that point of time, if he forcefully has sexual intercourse with his wife, that's called as raping your own wife. That's called as marital rape. So a female can lodge an FIR against him under section 376B. And lastly is 376C. Now 376C is fairly unique amongst the gang. What is the unique nature of 376C? Is that it punishes for an act of sexual intercourse which does not amount to rape. How can that be possible? That is exactly what is given in the question. Okay, consider a person who is a person in authority, and he uses that power of authority to either induce or seduce a female working under him or subordinate to him to have sexual intercourse with him. In that case, this is a situation which is made punishable under section 376C, right? Nitin Kumar has a question. Sir, how many marks will be good for this exam? My marks is 127. Nitin Kumar, we are not talking about how many marks. We are talking about how many more marks are going to be there, so that I feel confident that I don't need to get that half or 1 mark extra, right? तैयारी हमको ऐसे करनी है कि हमें ये सोचना ही नहीं है कि मुझे कितने मिनिमम मार्क चाहिए. तैयारी हमको ऐसे करनी है कि हम ये मान के चल रहे हैं कि अगर 1-2 सिली मिस्टेक भी हो गई ना, वैसे तो मैंने बोला सिली मिस्टेक नहीं करनी है, तो भी हम कॉन्फिडेंट है कि हमारा एग्जाम कहीं नहीं जा रहा. दैट्स द वे वी प्रिपेयर, राइट? सो I'll say go for 200 plus. Why not? Okay. So we have a decent leverage there. अच्छा, तुम अगर नीट पीजी की बात कर रहे हो तो वो सिचुएशन डिफरेंट हो सकती है, बिकॉज उसमें यू नो अगेन द सिचुएशन इज सेम कि आपको कितने मार्क्स चाहिए. 127 से ऊपर तो अपने को आना है, एंड देन एग्ज़ाम कितने मार्क्स का आता है. और आई वुड से फ्रॉम माई साइड एनीबडी हु इज़ एक्चुअली प्रिपेयरिंग टू, अगर हम प्रीवियस कॉन्सेप्ट पे देखें, जस्ट टेकिंग अ शिफ्ट फ्रॉम आवर नॉर्मल टॉक फ्रॉम दी क्वेश्चन, आई विल कम बैक देयर, कि 300 क्वेश्चन में से अगर आप कोशिश कर रहे हो ना कि मेरी अटैम्प्ट 280 से कम नहीं होनी चाहिए, यानी कि मुझे 20 क्वेश्चन ऐसे होंगे एग्जाम में जो मैं नहीं कर पाऊंगा, बट इफ़ यू आर प्रिपेयर्ड लाइक दैट कि मेरी अटैम्प्ट 280 से कम नहीं होनी चाहिए, आई एम टॉकिंग अबाउट एन एग्जाम विच हैज़ 300 क्वेश्चंस, then you are actually preparing good. But if you are considering that if I would not know, I am fairly fine with leaving 40-45 questions, I'll attempt close to 250, क्योंकि जो आप अटैम्प्ट करोगे उसमें काफ़ी सारे रॉन्ग होने की भी उम्मीद होती है, राइट? सो हमें तैयारी वो करनी है कि हम 280 या 280 प्लस क्वेश्चंस के लिए कॉन्फिडेंट रहे. ओके, गुड. सो अनिल का answer is 376B, sexual intercourse with own wife also living in separate. Yeah, that is exactly मैंने जो बात करी वही है. Good. Nice. So Nitin, sir, I am an FMGE student. I get that, Nitin. आज आप FMGE student हो, that is for today. once you clear your FMGE examination, you are a student which is going to head towards नीट पीजी एग्जामिनेशन ऑल्सो. और मैंने दोनों का पिक्चर आपको क्लियर किया. दोनों एग्जामिनेशन में हमें ये नहीं सोचना है कि हमारे को कितने मार्क्स कम से कम लाने हैं. हमें दोनों एग्जामिनेशन में ये सोचना है कि मुझे कितने FMGE के एग्जामिनेशन में प्रिपेयर फॉर हैविंग 200 प्लस. ओके, इवन इफ यू अंडरशूट, you are very very safe. In NEET PG examination, let's say if there is an exam of 300 question, our preparation should be that I'm not going to attempt less than 280. That's how my preparation should be. And I'm not saying 280 is the upper limit. Go for 290 plus if you are very confident, if you prepare very well. But do not prepare less than that, because then we are going pretty down on the basement. Okay. Right, so most of you have answered this question. That is very very good. And Apurva Shri ने तो एक mnemonic भी दे दिया. Thank you Apurva for making me learn that mnemonic. That C for career. And so if there is a sexual intercourse that has been compromised for career, it is punished under section 376C. Okay, great. Nitin, confuse mat ho. Okay, we will talk about it after the end of the session. मैं शायद अपनी बात आपको वैसे नहीं रख पाया जैसे मैं रखना चाहता हूँ. Let's finish up this session and I'll repeat those lines again. I will love to benefit you as vastly as I can. Okay, so अभी हम इस सेशन को आगे बढ़ाते हैं. So correct answer is 376C, which punishes for the situation which has been given in the question. On the crime scene visit by the forensic team, a doctor noted a greyish white color stain, trace evidence on the bedsheet while examining by magnifying lens. In the laboratory, reaction with the solution of potassium iodide and iodine water produces dark brown rhombic crystals. Which of the following is the trace evidence? Now the question which has been given, the reaction which has been given in the question, which contains potassium iodide, iodine in water, this reagent is called as Florence reagent, and this test is nothing but Florence test. Right, this is Florence test, and we do Florence test for detection of semen. That is what we read in our classes. We do it for detection of semen. So answer is very very simple. Florence and Barbario's are for semen. Teekman and Takayama, both the T's are for blood. So TT for blood and Florence and Barbario's for semen. Right, let's move ahead. Question number 8. A 35-year-old female who completed her family attended a gynecology OPD with complaints of dysmenorrhea, dyspareunia, painful defecation and urination. Sometimes she complained of pelvic pain before the start of menstruation. The doctor made a diagnosis of endometriosis and planned for a vaginal hysterectomy. During the surgery, the surgeon injured the ureter even after discharging his duty with care during the operation. So the most important essence of the question is written here. With care during the operation. The patient now filed a medical negligence case in the court, according to which of the following doctrines the doctor is not negligent in the above said case. So lot of history is given, and these kind of questions are expected in upcoming next examinations also, right? So what is doctrine of lex ipsa liquito? It means evidence speaks for itself. The doctor had to operate on left little finger, he wrongly operated on right little finger. Lex ipsa liquito. The evidence speaks for itself that negligence has happened. Doctrine of common knowledge, something which is very common to know. For example, if you visit a doctor after sustaining a wound, it is a common knowledge that he probably will dress the wound and give you antibiotic applications or probably antibiotics to eat. So it does not require any tactical or immense knowledge in depth to understand that open wounds require dressing or probably suturing. This is the information of common knowledge. So, these kind of things are called as rule of common knowledge. Here the patient has to prove that the doctor did not do something which was commonly expected to be done. Okay? That is all. Third is calculated risk doctrine. So, when you see res ipsa liquitor, and as I explained what is common knowledge, we can see that both these things, they go in favor of patient. Res ipsa liquitor go in favor of patient, because patient can simply say, see, left finger not operated, right finger operated, negligence. Common knowledge, something which is a matter of common knowledge not done by doctor, goes in favor of patient. Patient can, if patient can prove that it was not done. But in the question what has been asked, that according to which following doctrines the doctor is not negligent. So, what goes in favor of doctor is option number C, calculated risk doctrine. When a surgeon does a procedure and he explains the procedure to the patient and gains the consent, at that point of time they talk about the expected risks that are associated, even if due care and due concern is given to the patient. So, we are saying that calculated risk doctrine favors doctor, and that is going to go in his favor, and that calculated risk is established when we read in the question that the doctor discharged his duty with care during the operation. Okay. Right, and the doctrine of comparative negligence is in the cases of doctor and patient negligence, where the doctor and patient both had been negligent. The court establishes to what percentage the doctor is negligent and to what percentage the patient is negligent. This is called as the comparative negligence. Okay. Let us move further. Question number 9. Negligent act leading to patient's death is punishable under which section of IPC? This again is a very straightforward question and a very straightforward answer. We need to remember this, that is IPC 304A. This punishes for death due to negligence. If there is any death due to negligence of anyone including doctor, the punishment comes from 204A. The punishment is 2 years of imprisonment. Right. Question number 10, the last one, again a very straightforward one. Yes, these kind of single liners come. Cherry red color postmortem staining can be associated with which of the following? The answer is carbon monoxide, a very age old question. With nitrate we have brown color, hydrogen cyanide we have green, violet color, and with hydrogen cyanide we have pink color cyanide. Hydrogen sulfide we have green or violet color post-mortem staining. Right, this takes care of the discussion of the 10 questions. Thank you so much for being and participating. I will see you next time, and hopefully what I wanted to say, I guess, to Nitin, his question was I got 127 marks, and how many marks are needed. My suggestion to you, Nitin, is don't run after marks, how many marks are needed. You are somewhere around 40%. Aim for acquiring 70%. Even if you undershoot, you will be sitting comfortably around 60%. and that will never give you goosebumps after giving exam कि मेरे एग्ज़ाम का क्या होगा. ओके मैं आपको ये कहना चाहता था उस समय. ओके जितना भी समय हमारा बचा है, गो ऑल आउट. डू नॉट एम फॉर पासिंग द एग्ज़ाम बाय 2 या 3 क्वेश्चन. लुक फॉर पासिंग द एग्ज़ाम बाय गुड 15-20% मार्जिन. तब आपको ये हमेशा कॉन्फिडेंस रहेगा कि अगर मेरा पेपर थोड़ा भी ऊपर नीचे हुआ ना, मैं 50 से ऊपर हूँ. राइट. विद दैट आई लीव यू राइट नाउ. इट्स टाइम फॉर योर नेक्स्ट सेशन टू सम अप. आई विल सी यू नेक्स्ट टाइम. बाय बाय.
Okay, so hi, evening friends, evening everybody bache. I am Dr. Sushant Soni, MBBS MAMC, MD Pathology, Resident Hemato-Oncology, AIMS Delhi. And let's start with our pathology discussion. Isko we'll keep it as usual as a short sweet session. Everybody, please keep on telling me the answers side by side. The whole purpose of this session, see, this is the type of questions that you will be getting in pathology. So I want all of you to keep on telling me the answers A, B, C, D as we go further. So starting with our first question. Everybody, I'm not concerned whether you gave the paper or not. I'm giving you sufficient time to see the question and answer. Evening Anil, evening Dost, evening Sam, same is true with me also. So, 30-year female presented with wheezing, coughing and dyspnea apparently triggered after exposure to dust particles. Which hypersensitivity reaction is the patient suffering from? Evening Dost, evening everybody. I want all of you to comment on this. Dekho, you very well know there are 5 types of hypersensitivity, 1 to 5. One is asthma or allergy, that is the immediate type of hypersensitivity which occurs in exposure to dust particles. Type 2, antibody mediated hypersensitivity. 3, antigen antibody immune complex, whereas 4 is cell mediated or delayed type. And lastly is type 5 hypersensitivity. Lastly is type 5, which is again antibody mediated hypersensitivity, and there are just 2 diseases with type 5 hypersensitivity, that is myasthenia gravis. There are just 2 diseases, that is myasthenia gravis and Graves' disease. I am laying so much stress on this because this was last year's FMG question. Myasthenia gravis is which hypersensitivity? The best answer is type 5 followed by type 2 hypersensitivity. So if 5 is not given in the options, the next answer is type 2. And as we very rightly said, this was simple, straightforward. Type 1 hypersensitivity, allergy to dust particles. That is type 1 hypersensitivity. Next, which is the main cell? This line that we are writing again has been asked 3-4 times. Which is the main cell with respect to type 1 hypersensitivity? Type 1 hypersensitivity, main cell is mast cells. Mast cells followed by eosinophils, basophils and T cells. Eosinophils, basophils and T cells. Just a sec, let me write it clearly. Basophils and T cells. Next point, which is the stain used for mast cells? Toluidine blue. Which is the main cytokine which activates eosinophils? E is the fifth alphabet, no? A, B, C, D, E. Interleukin 5 followed by interleukin 4. Which is the main activator of basophils? B, second alphabet. Interleukin 3 followed by interleukin 4. Girl went to park, got stung by a bee sting leading to edema and anaphylaxis like reaction. Which is the main mediator associated? Histamine. It is which response? IgE mediated response. All these are recent MCQs. So with respect to dust particles, type 1 hypersensitivity. Next question. Biopsy of a patient with suspected breast cancer reveals presence of discohesive cells infiltrating tumor cells arranged in a single file pattern. What is the diagnosis? Answer. Everybody. Answer. Examiner has given you 2-3 hints in this question. देखो बच्चे, whenever we talk about carcinoma breast, we are talking of two main carcinomas, ductal carcinoma breast and lobular carcinoma breast. So firstly, examiner told you that it shows the presence of cells which are discohesive in nature. Discohesive means cells are singly scattered and they are present in a single file pattern, which is classically associated with lobular carcinoma breast. Gene mutation seen in lobular carcinoma breast, E-cadherin. It is associated with E-cadherin gene mutation. Which other tumor of the body also has E-cadherin gene mutation? Lobular carcinoma breast and signet ring cell adenocarcinoma GIT. And it is also seen in signet ring cell adenocarcinoma, signet ring cell adenocarcinoma GIT. E-cadherin gene mutation. Signet ring cell, good prognosis, poor prognosis? Poor prognosis. It is signet ring of the diffuse type, poor prognosis, E-cadherin gene mutation, also seen in lobular carcinoma breast. Next question. I had slightly less answers for the previous one, but I guess in this case, 100% answers. Firstly, the image itself is diagnostic. I need not even see the question. The second point is examiner is telling you about enlarged lymph nodes. Owl eye appearance is written also if you were not able to appreciate it, which were CD15 and 30 positive. Of course, it is Hodgkin's lymphoma, RS cells, Reed-Sternberg cells. Owl eye appearance other than Reed-Sternberg cells is also seen in cytomegalovirus, CMV, pneumonia. Most common organ affected by cytomegalovirus, lungs, that is CMV pneumonia. So before we go further, let us quickly have a look at classification of Hodgkin's. From this slide again, which we will not be astonished, see multiple myeloma is a favorite topic in oncohemat. The next favorite topic is Hodgkin's, so know this slide well. Hodgkin's is of two types, classical Hodgkin's lymphoma versus lymphocyte predominant. I will not be astonished if you get a question from this time. Classical Hodgkin's is of 4 types. That is mixellati, nodular sclerosis, lymphocyte rich. I know ये वाला topic हम लोगों को थोड़ा कम आता है. So see it with me once and for all in this 30 seconds and we will be done. Lymphocyte depleted. Most common Hodgkin's in India, mixellati, whereas most common in West, nodular sclerosis. Best prognostic Hodgkin's, lymphocyte predominant. More the number of lymphocytes, better is the prognosis. Best prognostic, lymphocyte predominant. Worst prognostic, lymphocyte depleted. Hodgkin's is associated with 2 viruses, HIV and EBV. Most common Hodgkin's associated with HIV, mixellati. Most common Hodgkin's with EBV, mixellati. So with respect to Hodgkin's, if you do not know the answer to something, the answer is mixellati. Hodgkin's lymphoma has RS cells which are CD15-30 positive, except the RS cells seen in lymphocyte predominant Hodgkin's. देखो lymphocyte predominant is on the other side, except RS cells in lymphocyte predominant Hodgkin's which are 15-30 negative. So I want you to tell me what are they positive for, which CD marker. Firstly, easy है. You went to the market, 15 rupees भी नहीं 30 भी नहीं भैया बीच का लगा लो, it is CD20 positive and these RS cells are called as popcorn cells. They are called as popcorn cells. This is Hodgkin's lymphoma. Next question, a good one. In the sense that when students gave the paper, we totally agreed, bache, CD20 positive. Now have a look at this question. When students gave the paper, they made the diagnosis right, but somehow got confused in the options. So I'm giving you 10 seconds, but give me the right answer. A young female, 35 female, went to the clinic with easy bruising and petechiae over the skin. Petechiae is the presence of small hemorrhagic spots, as is visible in the image also. There is no history of trauma. There are small purpuric lesions present on her skin, as shown in the image, with a low platelet count. Platelet count is low. PT and petechiae are normal. That means it is a case of plain and simple thrombocytopenia. Which is the most likely cause? Answer, ITP. Diagnosis in this case is ITP, immune thrombocytopenic purpura, ITP. Answer, what is ITP? Immune. It shows the presence of antibodies against GP1B and GP2B3A present on platelets. It has antibodies against GP1B and GP2B3A present on platelets, ITP. Of course, it is not deficiency of ADAMTS13. ADAMTS13 deficiency leads to TTP, thrombotic thrombocytopenic purpura. The patient would have a history of multiple thrombosis, in turn leading to thrombocytopenia and purpura. This is not a case of TTP, this was a case of ITP. C, the answer in this case was C. D nahi bache, D nahi. This is not, Nitin, this is not factor VIII deficiency. This is hemophilia A. And how does hemophilia A present as? Both factor VIII 9, hemophilia A and B present as hemarthrosis, deep thigh hematomas or bleeding in deep knee, in the knee joint or joint spaces. Hemarthrosis with deep thigh hematomas. This is not petechiae and purpura, so the answer D was out. Answer was C. Next question. Which of the following markers is associated with medullary carcinoma thyroid? Answer, calcitonin. So let us quickly have a look at tumor markers. Starting with one of the most famous ones, AFP, alpha fetoprotein. Of course, it is elevated in HCC, hepatocellular carcinoma. Other than HCC, it is seen in which ovarian tumor? Please keep on writing it in the chat box. Yolk sac tumor ovary. It is seen in yolk sac tumor ovary. Next, small cell carcinoma thyroid. Next, or let me rephrase, small cell carcinoma lung. It is NSE positive, neuron specific enolase, NSE positive. The four main CA markers, I want you to tell me this. CA 125, keep on writing it in the answer box, 125. Next, 72.4, CA 15.3 and CA 19.9. See, this is how we will remember if we go wrong. CA 125, majority of you are usually right in this, ovarian cancers. CA 72.4, for 72 rupees we take the ice cream. So 72.4, gastric cancer. 15.3, agreed. Next, CA 15.3, at 15 years breast development starts, breast cancer. Versus CA 19.9, that is pancreatic and colon cancer. CA markers extremely important. Next, beta 2 microglobulin. It is a poor prognostic marker associated with multiple myeloma. I am laying so much stress on this. As such, multiple myeloma is an important topic, and this was this time's NEET PG question. So again, multiple myeloma, there is a major overlap between the FMGE and the NEET PG segment. So beta 2 microglobulin, multiple myeloma. Agreed. But along with pancreatic, Apurva Zevi, we will write colon cancer also. 19.9 is used with both, more specific with pancreatic, but also with colon cancer. And lastly, CEA, carcinoembryonic antigen. It is a non-specific marker seen in adenocarcinomas of the body. Adenocarcinoma lung, colon, pancreas and ovary. Colon, lung, pancreas and ovaries. CA. Sufficient. So this was with respect to tumor markers. Next point. Which trinucleotide repeat is associated with Huntington's? I guess 100% right answers. All of you know this mnemonic also, that hunter keeps the animal in cage. CHE. versus which is the classical trinucleotide repeat disease? Fragile X syndrome. In Fragile X syndrome, patient is mentally retarded. Most common genetic cause of mental retardation, Downs, followed by Fragile X. So Fragile X patient को कम ज्ञान है trinucleotides से CGG versus Huntington's CAG. All of us, we have 30 to 60 repeats. जैसे CGG, 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 CGG. It is repeated 30 to 60 times. Then there is a pre-mutated state where they are repeated 300 times and a mutated state where they are repeated 3000 times. This is not important. What is important is mutation increases from mother to the child. This principle is called as anticipation. This is called anticipation. Anticipation or Sherman's paradox. Anticipation or Sherman's paradox. That is increasing severity of disease with successive generations. Increasing severity of disease. We are anticipating that the child will be more severely affected than the parents. Increasing severity of disease with successive generations. This is paradoxical. Parents are supposed to protect us, na? Here the disease is increasing from parent to the child. So Huntington's trinucleotide repeat disease, CAG. Next, simple, straightforward. I guess a stupid question, but I have put it just to tell you that this was this December 2022 FMG question. So you get questions like this: macrophages of liver, Kupffer cells; kidney, mesangial cells; blood, macrophages of the blood, monocytes. देखो, there is no confusion in this at all. Confusion occurs in brain, glial cells, microglia, oligodendrocytes या ependymal cells. Microglia. Brain, microglia. Spleen, I want you to tell me, spleen, cytotrophoblast, syncytiotrophoblast, या littoral cells. Macrophages of the spleen. I'm waiting for that answer. And lastly, placenta. So spleen, littoral cells, placenta, cytotrophoblast, syncytiotrophoblast, या Hofbauer cells. Spleen is littoral, I agree. Placenta. But syncytiotrophoblast is the giant cell of the placenta. The macrophage is Hofbauer cells. Macrophage. हमें pregnancy से Hof है ना, डर लगता है. So macrophage of the placenta, Hofbauer cells. Giant cell is syncytiotrophoblast. Syncytium is the cells are joining together, so it has multiple nuclei. Agreed. Next, a good question. Now finally this is a question in which the examiner did not limit themselves to just the diagnosis. पहले तो diagnosis देख लेते हैं. 10-year-old child with symptoms of malaise, fever, hematuria. Hematuria means cola colored urine or cocoa colored urine. I don't even know what is cocoa. I guess it's a fancy coffee bean. Doesn't matter, cola colored urine or cocoa colored urine. Lab investigations show ASO titer is increased, low C3. So जो भी हम लोगों को पता था, examiner gave everything in the question itself, that this is a case of PSGN, post-streptococcal glomerulonephritis. Child with features of nephritic syndrome. Most common nephritic syndrome in children, PSGN. It is associated with hypocomplementemia. C3 is reduced. On immunofluorescence, it has the classical starry sky appearance. You also know that. Next, ASO titers are elevated. So diagnosis is of course PSGN. Answer, ABCD. Now that is the main point. Answer. Normally in FMG exam, people limit themselves to diagnosis. We have gone a step further. Answer. PSGN has subepithelial deposits called as humps. देखो बच्चे, humps are seen in PSGN versus spikes which are seen in MGN. Both humps and spikes are subepithelial in nature. Extremely important, both of them. So PSGN and MGN, most common site of deposit is a subepithelial deposit. Versus lupus nephritis. Please have a very good look at this slide. Lupus nephritis. The most common class of lupus is class 4 lupus, which has a subendothelial deposit. So PSGN and PSGN and MGN have a subepithelial deposit versus lupus nephritis, which has a subendothelial deposit, microscopically showing the presence of wire loop lesions. Microscopically showing wire loop lesions. This is lupus. Never give up. But I agree with your point that flea-bitten appearance of the kidney can be seen in PSGN along with IgA nephropathy and Wegener's disease. But classically, when we talk of the FMGE exam, classically when we talk of flea-bitten appearance of kidney, grossly, I want all of you to tell me flea-bitten appearance of the kidney with onion skin appearance microscopically, which is a feature of malignant hypertension, seen in malignant hypertension. Next point, but you are right, along with malignant hypertension, it is seen in PSGN, SABE, subacute bacterial endocarditis, Wegener's granulomatosis, and IgA nephropathy. You are technically right. Next point, so spikes are seen in MGN, humps are subepithelial in nature, they are not subendothelial. Mesangial deposits are seen in IgA nephropathy or Butcher's disease. So this was with respect to kidney. If you know this question, if you know this slide, you will be right in at least one question of kidney. Next question, all are criteria of RHD except. In this question, I want you to tell me the answer, ABCD, and along with that, I also want you to tell me this particular answer is seen with which disease. For RHD, we use the modified Jones criteria. Which is the most common major criteria? Most common major criteria being migratory polyarthritis. Pain is migrating from one joint to another. Large joints are affected, hips, knees, elbows. Next, it is associated with pancarditis, erythema marginatum, subcutaneous nodules, and Sydenham's chorea. Which of the following is not a feature? Pyoderma gangrenosum. Gillespie, which I totally agreed. Stadiska is also seen in Burkitt's in lymph node biopsy. Agreed, dear. Agreed. Now, my question to you is Pyoderma gangrenosum. We will have a look at 4 skin lesions. Erythema marginatum, RHD. Erythema marginatum, it is associated with RHD. Pyoderma gangrenosum, I want you to tell me. Next, what is the name of the skin lesion with diabetes? The black patch that we see. Acanthosis nigricans. Acanthosis nigricans, diabetes. And lastly, in which disease we cannot eat wheat? नहीं बच्चे, pancarditis तो है ना, ZV. Pancarditis is a feature of RHD. Of course, rheumatic heart disease, heart is involved, so pancarditis will occur. Next, in which disease we cannot eat wheat? Celiac disease. Which is the skin lesion with celiac? Which was the most romantic place in first year MBBS? DH, dissection hall. So skin lesion with celiac, DH. That is dermatitis herpetiformis. DH, dermatitis herpetiformis. My question still remains, Pyoderma gangrenosum is associated with which GIT disease? That is a huge hint. Which GIT disease? IBD, inflammatory bowel disease. Which one? Ulcerative colitis. But please have a good look at this. Ulcerative colitis, Pyoderma gangrenosum. So these are the skin lesions with other diseases. Next, this exact question has been asked twice. Just to reinforce the same point, you always in FMG exam mark the most common. Now, patient underwent had recent onset of seizures, biopsy, CT was done, there presence of semoma bodies as is depicted in the image. So, examiner also told you that what is seen in the image are the semoma bodies. All these are the semoma bodies, and microscopically it shows whirling with semoma bodies. This time's December 2022 FMG question seen in meningioma. So most common CNS tumor. Answer, bache, I want all of you to tell me this. Most common CNS tumor. Next, most common primary CNS tumor. This is meningioma. Followed by gliomas. Most common CNS tumor, metastasis. Please don't go wrong in this. In lungs, liver, heart, brain and bone. I'll repeat, lungs, liver, heart, brain, that is CNS and bones. Most common tumor is metastasis. Next, most common primary CNS tumor, meningioma, which shows the presence of pneumoma bodies and microscopically shows swelling. Most common primary malignant CNS tumor. Every time we keep on adding one word. Most common primary malignant CNS tumor in children is medulloblastoma versus adults, that is glioblastoma multiforme. Children, medulloblastoma versus adults, that is glioblastoma multiforme. Never give up. You were right about metastasis and Nitin's over you. But most common CNS tumor, metastasis. Asha, one more thing. Most common primary CNS tumor in children. Overall, most common primary CNS tumor is meningioma. In children, pilocytic astrocytoma. Next question. 100% right answers. I mean, there is absolutely no doubt in this question at all. A 50-year male, that is adult with gum bleeding, 70% cells are blasts which are MPO positive. MPO is which marker? It is a myeloid marker, AML. Most common leukemia in adults, AML. Most common leukemia in children, ALL. An adolescent with acute leukemia presenting with mediastinal mass, TALL. देखो बच्चे, when we talk of leukemias, most common leukemia in children, BALL. Most common acute leukemia in adults, that is AML. Next, mediastinal mass. Acute leukemia with mediastinal mass, that is TALL. Afzal, that is what Nathan, I'll explain you all. So, tumor with acute leukemia with mediastinal mass, TALL. When we see the presence of smudge cells, high TLC with presence of smudge cells, diagnosis, smudge cells are a feature of CLL, that is chronic lymphocytic leukemia, CLL. Lastly, when you see all the cells, that is the presence of blasts, promyelocytes, myelocyte, blast, promyelocyte, myelocyte, metamyelocytes, basophils, basophilia with eosinophils and hepatosplenomegaly, diagnosis CML, chronic myeloid leukemia. I'll repeat. Child with acute leukemia, ALL. Adult with acute leukemia, AML. Adolescent with acute leukemia with mediastinal mass, TALL, T for Tata, TALL. Smudge cells, high TLC, adult with high TLC with presence of smudge cells. Smudge cells, girls know it well, the mascara is smudged. For the guys, cell toota hua hai, fella hua hai, CLL. And if you see all the cells together, CML. Translocation 922 Philadelphia chromosome. Which is the protein formed? BCR-ABL. Everybody, please give me a thumbs up if all of you are comfortable with all these points. We have covered Burkitt's, we have covered the acute leukemia, CLL, CML, Hodgkin's lymphoma, and of course multiple myeloma, the prognostic marker being beta-2 microglobulin. Everybody, please give me a thumbs up or like the video if all of you are comfortable with all the points that we have discussed till this point. Next question. A 12-year child with Phe508 deletion of 508th amino acid, which is phenylalanine, on chromosome 7 presents with recurrent pulmonary infections. My diagnosis was made here only. Child with 508th amino acid, that is phenylalanine, deletion of phenylalanine present on chromosome 7, recurrent pulmonary infections. Examiner did not write salty sweat. Salty sweat with increased risk of lung infections, chromosome 7 mutation, diagnosis CFTR. Even if you were not able to make a diagnosis of CFTR, cystic fibrosis, gene mutation, CFTR gene mutation, chromosome 7, all the options are of CFTR as such. All options are cystic fibrosis. Now, point to be noted here is, what did you mark? A or B? Firstly, देखो, cystic fibrosis diagnosis was obvious because all options were cystic fibrosis. Students in this question got confused between A and B. Bache, the pathogenesis in lungs, GIT, and and the male genital tract is different from the pathogenesis in sweat ducts. In sweat ducts, there is salty sweat, increased secretion of sodium and chloride in lumen. Versus in lungs, GIT and male genital system, there is reduced, or let me rephrase, there is increased absorption of sodium and chloride in the cell. बिल्कुल opposite है. In lungs, GIT, more sodium and chloride is present in the cell. Versus in sweat ducts, more sodium and chloride is present in lumen. That is why there is salty sweat. नहीं भी समझ आया तो does not matter. The pathogenesis is opposite. So the answer is not B. It is not increased chloride secretion. No. It is a mutation in CFTR gene due to abnormal folding and trafficking. It is not always associated with increased chloride secretion. It depends upon the organ. Increased chloride secretion is only seen in sweat ducts. In lungs and GIT, there is reduced secretion of chloride. So answer was not B those. Answer was A. This was slightly tricky. And this gets us to our last question in pathology. Before we discuss this, fatafat say, do tell me how is the paper. There were many questions of medicine also which you could answer on the basis of pathology, of course. But how were these questions? I mean, simple, straightforward. I am sure that when you will give the paper, actually go and give the paper actually also, you will be very comfortable with it. So which statement describes the serology of hepatitis B? HBs antigen is negative. Which is the first antigen to appear? Dekho, if this is the serology, the first antigen to appear is hepatitis B surface antigen. Till the time infection is present, HBs antigen will be positive. After the infection becomes alright, after a long time comes anti-HBs antibody. After a long time comes anti-HBs antibody. The time period between disappearance of HBs antigen and appearance of anti-HBs antibody is called as window period. The time period between the two is window period. When symptoms of the patient are at their peak, HBe antigen is positive. So I can safely say marker of viral proliferation is HBe antigen. Another marker of viral proliferation is HBV DNA copy number. Ki actually how many DNA copies are there? Which is a better marker of viral proliferation? HBe antigen or DNA copy number? HBV DNA copy number. It's a much better marker because that tells us the exact number of copies. Which antigen is never secreted in bloodstream? HBc antigen. So antibody against it, that is IgM anti-HBc antibody is the first antibody to appear. IgM followed by IgG anti-HBc antibodies. So which antibody is seen in acute infection? IgM anti-HBc antibody. First antigen to appear, HBs antigen. First antibody to appear, IgM anti-HBc antibody. Best marker of window period. Best marker. Oh, something went wrong. Best marker of window period, IgM anti-HBc antibody. Till the time infection is present, HBs antigen will be positive. So now have a look at the question. HBs antigen is negative. That means infection is not there. So patient is acute HBV is wrong. Patient has chronic hepatitis, not at all. Because in chronic hepatitis, HBs antigen has to be positive. Chronic with high infectivity, low infectivity, does not matter. If it is high infectivity, in chronic HBV, if it is a case of high infectivity, HBe antigen will be positive. Which is the marker of viral proliferation? HBe antigen. If it is low infectivity, HBe antigen will be negative. But as long as it is chronic infection, as long as infection is present, HBs antigen has to be positive. In this case, HBs antigen was negative. Both the antibodies were positive. In the question, both the antibodies are positive. That means it is a previous infection. It is resolving in nature. So the answer was D. The answer was D. This was with respect to hepatitis B virus. Acha, lastly, tell me this also. Post-immunization, what is present? We are giving a mimicker of HBs antigen. So only anti-HBs antibody is present, nothing else. HBs antigen, HBe antigen, anti-HBc antibody, anti-HBe antibody, all others are negative. Only anti-HBs antibody is positive post-immunization. Done. This absolutely takes care of our pathology discussion, but no doubt we are in this together. I mean, कई बार लगता है कि we are facing more difficulties in life and ठीक नहीं चल रहा है, ये नहीं हो रहा, वो नहीं हो रहा. All of us are in the same boat. You know much more than what you think, and this is a stupid paper. Go and give it. You are going to ace it. You are going to perform much better than you expect. Just keep on studying. Take care, and bestest of luck.
Alright, hi guys, so let's get started with the grand test discussion today in pharmacology, which was conducted on computer-based offline test. So in pharma, we have roughly around 13 questions, and let's quickly see what are the possible answer of those questions, and also where have you made mistakes in these questions. Okay, so these are all very easy questions. As I was going through the question, I saw that they were talking about a pregnant female who is coming to the emergency department with 3-day history of cough, sore throat, rhinorrhea. Okay, so there is upper respiratory tract infection. She is taking a medication for upper respiratory tract infection from a local chemist. So sometimes they use the term self-medicated, or she is taking from a local chemist. After seeing the medication, the doctor told the child could be possibly affected with a pyloric stenosis. So what the examiner is asking, which particular antibiotic or which particular drug that has been taken for upper respiratory tract infection can cause pyloric stenosis. So as simple as that. Earlier time, what they used to do, they simply ask which of the following drug can cause hypertrophic pyloric stenosis. Now they have given a case-based scenario, same thing with a different form. So correct answer to this question, every one of you are well aware, and we have discussed a list of teratogenic drugs. So in my lectures I have given you 15-16 teratogenic drug, and there is a table I have given you, and from that table there is a definite one question that you are going to get in any examination that you are going to practice. Okay, so erythromycin is one such drug among macrolide that is usually associated with this teratogenic effect that we call it as a congenital hypertrophic obstructive pyloric stenosis. Sometime instead of using this term, they use the term as a newborn with vomiting, or they will say non-villous vomiting, newborn with the non-villous vomiting, and upon X-ray string sign is seen. Upon X-ray there will be a sign known as your string sign. I mean barium study, barium study, they give the information like string sign is seen. Which of the following drug exposure could have caused? Same question can be given in different language. So again, the answer to this question is none other than your erythromycin. Now what about other drug? Are they also teratogenic? Yes, like cotrimoxazole as a drug. It's a combination of trimethoprim and sulfamethoxazole. What it can cause? It can lead to a situation known as your kernicterus. Sometimes they don't use the term kernicterus, they use the term yellow baby syndrome. Yellow baby syndrome. Now this drug will be causing dissociation of bilirubin from its binding protein. This bilirubin can easily traverse through the blood-brain barrier because newborn's blood-brain barrier is poorly formed. So this excess bilirubin in the brain will be leading to a scenario kernicterus. Another question, same topic, another framing of question, which of the following antibiotic can lead to permanent neurological damage? So this is one agent that can cause permanent neurological damage to the baby. Chloramphenicol, it's a protein synthesis inhibitor. This will be associated usually with the scenario known as your gray baby syndrome. Gray baby syndrome. Streptomycin, it will be associated with ototoxicity, nephrotoxicity. Now, as I said that we have discussed already 15-16 list of teratogenic drug. We are not going to discuss the same because again that will be simply a repetition. You can check it out. It's easily available in general pharma chapter. You will be finding that. Then in the recent examination 2022, they asked this question that the teratogenic effect associated with the fluoroquinolone. So fluoroquinolone, all the ofloxacin, ofloxacin, ciprofloxacin, moxifloxacin, they will be associated with the teratogenic effect known as your tendinitis and arthropathy. So what they gave, actually the question was reversed. that mother was exposed to an antibiotic, the baby is born with the tendinitis and arthropathy. Sometimes they use the term tendon rupture. Now this tendinitis arthropathy, it is not only teratogenic effect. Even adults also who are going to get exposed to this fluoroquinolone can develop tendon rupture. Okay, so this fluoxacin was the answer to that question, that newborn is having tendinitis and arthropathy. Which of the following drug was the possible exposure here? So that was fluoroquinolone. So 5 important drugs that I have shown you that is having teratogenic effect. Okay, correct answer to this question is C. I hope all of you guys have got this correct. Let's see the next one. 40-year-old patient with MRSA infection admitted to the hospital and was started on IV therapy. Now first and foremost, you should see, whenever you see that when the patient was diagnosed with MRSA, what is the drug of choice in MRSA? Methicillin resistant staph aureus, that is known as your vancomycin. This thing is pretty clear to all of you guys. Now let's read the question again. He was started on the treatment of this infection. Shortly after the infusion of the drug, the patient developed pruritus, flushing, erythema, right? So they are actually taking towards a very simple side effect. Earlier they used to ask which of the following drug causes Redman syndrome. Now they are asking you after giving you a case scenario, right? So rapid IV infusion of this particular drug vancomycin, it will be causing your mast cell degranulation. That will be causing release of the histamine, and this release of histamine will be leading to a scenario known as your Redman syndrome. Now this redness, that is flushing and erythema, this redness is seen first around the neck. So sometime it is also given the name as a red neck syndrome. So Redman syndrome, red neck syndrome, it's the same thing, right? So correct answer to this question is none other than your vancomycin. Now in 2022, there was one question also. A patient was started on linezolid. Which of the following investigation you should keep in mind, or you should do on a priority basis? So see, linezolid is one such drug that is associated with multiple side effects. Okay, so it is actually associated with one important side effect, that is known as your bone marrow suppression. And most common in the bone marrow suppression will be decrease in the platelet count. PLT is platelet count. It can also cause many other side effects, but nausea, vomiting, rashes. In addition to that, specific one, bone marrow suppression, more common, decrease in the platelet count, and they can also lead to a scenario known as your serotonin syndrome. Because of its MAO inhibiting property, it will be causing serotonin syndrome. So these two side effects are very commonly associated with linezolid. Astronam, it's one of the monobactam. It is not necessarily associated with these kind of side effects, nausea, vomiting. It's usually a safe kind of drug. Meropenem, again, it's carbapenem, so they will be having usual side effect like nausea, vomiting, rashes and all. So no specific side effect like serotonin syndrome or Redman syndrome with meropenem or astronam. Okay, so I hope all of you guys have got. Now what is meropenem? It's a carbapenem. It's one of the beta lactams. Okay, next question. In which phase of clinical trial new treatment is compared with the existing one? Always remember that what is phase 1 that we are going to do. In phase 1 we usually do safety. Phase 1 is mainly for what? We are trying to define the safety, or we say maximum tolerable dose assessment. Assessment of the maximum tolerable dose is done in which phase? So that will be in phase 1. Phase 2, we are going to mainly determine the efficacy. So we have safety, we have efficacy, and what about phase 3? Here we are going to confirm the efficacy. So we also call it as a confirmatory trial. And I want you to remember with one more name, comparative trial. So we are going to compare the existing drug with the newer one. So to one group you will be giving the existing drug, to other group you will be giving the newer drug, and you will be doing the analysis. So confirmatory trial or comparative trial. What about in phase 4? Phase 4, there is no limit on the sample size. So we are going to do post-marketing surveillance. So if you want to remember in this way, well and good. Other than that, safety, efficacy, confirmatory, sick post. I want you to remember by the simple mnemonic of SEC. S-E-C, sick post. Yeah, SEC post. Safety, efficacy. C stands for two things. Either confirmatory, that we are going to confirm the efficacy, or comparative trial. So here we are going to compare the existing one with the newer one. SEC post will be post-marketing surveillance. So SEC post is a very, very simple way to remember all of them. Alright. So if you want to compare, the correct answer to this question is phase 3. Then if the examiner is going to ask you that in which phase of the clinical trial maximum failure is going to happen. Maximum failure. So that will be happening in phase 2 clinical trial. Then if they are going to ask you that blinding is done in which phase of clinical trial? So blinding will be done in phase 2 also, and blinding will be done in phase 3 also. The sample size in phase 3 will be around 1000 to 5000, on an average around 3000. In 2 it will be 200 or up to 400. 200 around 400 है ना. So 2 को 200 से याद कर लिए, 3 will be around 3000 है ना. That's one thing. Blinding will be done in which one? Phase 2 and phase 3. Then open label study is which one? These are all MCQ. Open label study. That means everyone is aware who is taking what kind of drug, what is the possible ADR. Open label study. So phase 1 will be open label study. Phase 1 will be open label study. Phase 0 will also be open label study. What about phase 4 clinical trial? Is it open label? Phase 4 is post-marketing surveillance. It is also an open label study. We are not going to do blinding in this phase as well. Okay. So again, remember safety, efficacy, confirmatory, sec, post, second, post. Okay. SEC second, yeah, sec, post. All right. Mechanism of action of botulinum toxin. I mean, how easy, you know, this question is. So botulinum toxin, it simply inhibits, let's say this is a presynaptic neuron, and inside the presynaptic neuron we are having acetylcholine. So for acetylcholine we are having A for acetylcholine, B for botulinum toxin. It inhibits the release. So how do I ask you to remember that botulinum toxin बाहर नहीं आने देगा. Botulinum toxin बाहर नहीं आने देगा किसको? Acetylcholine को. So it is the botulinum toxin that is going to inhibit the release of the acetylcholine. By inhibiting the release of the neurotransmitter, by postsynaptic block, by neurotransmitter reuptake, by inhibiting acetylcholine esterase. See, very simple. Botulinum toxin बाहर नहीं आने देगा, so inhibiting the release of the neurotransmitter. Now, can we quickly cover the other options as well? Like option C says neurotransmitter reuptake inhibitor, right? Neurotransmitter reuptake or inhibiting the acetylcholine esterase. So they both are almost similar thing only. Let us quickly see that one is acetylcholine is released. Let us say these are all dots are acetylcholine, and once acetylcholine is released, once the action is done on the receptors, now they are supposed to get broken down with the help of enzyme known as your acetylcholine esterase. The name of the enzyme is acetylcholine esterase. This will be causing breakdown into choline plus acetate. The breakdown will take place into choline plus acetate. Acetate will be excreted. Choline is supposed to get reuptaken once again. है ना? Right? Choline will be reuptaken once again. Uptake of choline. So now two things. One is acetylcholine esterase inhibitor. So what is the drug that can inhibit this acetylcholine esterase? So we have many drugs actually. They are actually cholinergic drugs. They can increase the acetylcholine at the synaptic cleft. This drug is going to be drugs like your neostigmine, pyridostigmine, physostigmine, all of them. And the one that is going to inhibit the reuptake will be hemicolinium. So inhibiting the reuptake will be specific drug hemicolinium, although we are not using them clinically, but just good to know. Hemicolinium, right? Hum hai colinium, right? Hemicolinium या हम शक्ल of colinium we say. Okay, so they will mimic the choline action and they will not allow the choline to get uptaken, and hemicolinium will be going inside and they will be causing a fake neurotransmitter synthesis. Okay, so these are the two important things. Post synaptic block will be all, you know, receptor blockers, M3 blocker like M2 M3 blocker like atropine, or M1 blocker like paranzapine, telanzapine. They will all be post-synaptic receptor blocker. Okay, so botulinum toxin bahar nahi aane dega. What are the different uses of botulinum toxin? See, we are having multiple uses actually. Important one, like for example, it can be used in chronic resistant migraine. Chronic resistant migraine ka prophylaxis mein we can use. We can also use them in axillary hyperhidrosis. Axillary hyperhidrosis. Please remember, it's a FDA approved drug for prophylaxis of migraine. Every 12 weeks it is injected. है ना? Chronic resistant migraine का prophylaxis, axillary hyperhidrosis, spastic cerebral palsy for reducing the spasm. Spasm you can reduce, and you can also use them in spasmodic dysphonia. Torticollis, है ना, एक्लेशिया कार्डिया, ए से एक और लिख लीजिए, एक्लेशिया कार्डिया. There are many uses actually. There are many uses. Important one only I am writing here: chronic resistant migraine, axillary hyperhidrosis, as the name suggests, axillary hyperhidrosis, achalasia cardia. If you want to reduce the lower esophageal sphincteric tone, it will be given injectable. Spastic cerebral palsy, spasmodic dysphonia, and torticollis for the treatment of blepharospasm, and very important for the beauty treatment. For the beauty treatment also we can use them. So again, remember, you'll be casted if you are beautiful. You'll be casted if you are beautiful. Just a way to remember. Beauty treatment ke liye also, or we also call them as facial wrinkles. Other term is also facial wrinkles to be utilized by the models. Okay. A professor during Viva was asking a student about the potential effect of dopamine as intermediate doses. So I think again professors ka favorite questions hota hai during Viva, usually clonidine, atropine, and these drugs, dopamine, dobutamine. Okay, and which receptor does it work? Which of the following would have been the response from the student? What would have been the response? So response from the student would have been anything. They can say anything. So it will be causing mydriasis. They can give any information, I mean, about the student. But ideal examiner is asking here that, remember, dopamine as a drug, it is going to act on the dabba. What is the mnemonic that I told you? D1, beta 1, alpha 1. It is going to act on the dabba. Why dabba? Because the action of dopamine is dose dependent and it will be following the same order. That means at the lesser dose, in a dose of less than 2 microgram per kg per minute, they will be stimulating D1 receptor. Because of that, there will be vasodilation. So this was one of the question in 2021, that in the lowest dose, what is the possible outcome? Vasodilation. B1 in a dose of 2 to 10 microgram per kg per minute, they will be stimulating beta 1 receptor. And because of that, there will be increase in the heart rate. So this is the intermediate dosage. And last but not the least is the alpha 1. Any dose more than 10 microgram per kg per minute, they will be stimulating alpha 1 receptor. So usually a patient of shock with oliguria, we are going to prefer this dose of more than 10 microgram, right? So if the examiner is going to ask you in the intermediate dosage, so I think this is your answer. Correct answer to this question, it is going to be D1 vasodilation at the lower dose. This is at the lower dose, okay? Alpha 1 vasoconstriction at the highest dose. Beta 1 inotropic. So if the beta 1 is stimulated, increase in the heart rate, increase in the force of contraction again. It does not act on the M1 receptor. Okay, dopamine has no action on the M1 receptor. All right. As I told you that B1 dose, we can use them in acute heart failure, and alpha 1 dose that we are having heart failure in a patient with the shock with oliguria. Acute heart failure में second वाला intermediate dose we can use. A 60-year-old man accompanied by his grandson to OPD who complains that he has been forgetting things. Okay, so again, elderly male forgetting everything. You can think of only one condition, that will be Alzheimer's disease. The physician makes a diagnosis of Alzheimer's disease. Okay, so diagnosis has been well solved for all of you guys. Which drug can be used for dementia and is an NMDA antagonist? So see, donepezil, galantamine, rivastigmine, all of them, they are the reversible acetylcholine esterase inhibitor, and they are going to increase the level of acetylcholine. There is a degeneration of the cholinergic neuron. So definitely acetylcholine in the brain will be helpful for this patient. Out of all of them, donepezil happens to be the drug of choice. Now, why is it drug of choice? Because it is longer acting, lesser side effect. It's the drug of choice in a patient with the Alzheimer's disease. But examiner is not asking this. Clearly saying they're not asking drug of choice. They are asking which of the following is an NMDA antagonist. So only one among the NMDA antagonists that can be utilized will be your memantine. It is having neuroprotective property. NMDA antagonist, there will be lesser neuroexcitotoxicity. NMDA is a receptor of what? Glutamate. Glutamate is excitatory neurotransmitter. So there will be lesser excitotoxic damage here when you give memantine. All right. Now there are two more drugs that I would like to discuss for all of you guys. One is known as your aducanumab. Lecanemab. So again, see NUNE, है ना? So again, they are actually talking about some neuronal, right? So these are the monoclonal antibody that is recently approved for beta amyloid, right? Beta amyloid plaque against monoclonal antibody against beta amyloid plaque or protein, and this is also one of the drugs that can be utilized in Alzheimer's disease. So these are the two newer monoclonal antibody that has got approval for the Alzheimer's disease. Okay. There was one more agent, solanezumab. No? We are not using that anymore. That didn't got approval actually. 32-year-old female with a history of epilepsy present for a routine follow-up at the neurology clinic. She has been prescribed phenytoin. Okay, so phenytoin is an anti-epileptic drug, voltage-gated sodium channel blocker. And as a medical student in the department, the physician asks you to identify the statement that does not accurately describe the phenytoin, which does not describe. So what do we know about phenytoin? First and foremost, let's see. Phenytoin is a drug that is one of the anti-epileptic drug. It's an anti-epileptic drug. It is a voltage-gated sodium channel blocker. Therefore, they will decrease the glutamate release. Not only that, it also has anti-arrhythmic property. So, important points, I'm just writing it down. Anti-arrhythmic action, class 1B anti-arrhythmic drug. It also enhances the wound healing. It also has wound healing property because of the anti-collagenase activity. Wound healing property. Alright. These are the important things that we know about phenytoin. I mean, we know many things, but important ones I am writing it down. And apart from that, remember, it is also one of the drugs that is a narrow therapeutic index. Narrow therapeutic index. And because they are narrow therapeutic index, remember, therapeutic drug monitoring is always and always required with this class of drug. Do remember, it also follows zero order kinetic. Now, they follow zero order kinetic only at the higher doses. They follow zero order kinetics only at the high doses. What do I mean by this? That means if you are going to use a dose of 10 to 20 microgram, 10 to 20 microgram, if the therapeutic plasma concentration is 10 to 20, that means they will be following first order. We don't have any problem. There is no problem if you are using, if the level is between 10 to 20. So, this is the therapeutic plasma concentration actually. This is the therapeutic plasma concentration. If the level goes beyond 20 microgram, then they start following zero order. Now they start following zero order. So that is when the problem starts, when the plasma concentration is increased to more than 20. So two questions that has been asked, which of the following is having narrow therapeutic index, or what is the therapeutic plasma concentration? So 10 to 20 is the therapeutic plasma concentration, and in this one they will be following first order. In the higher dosages they will be following zero order kinetics. Now let's read the question. Phosphenytoin is a water soluble product. Yes, phosphenytoin is a water soluble product, and they are also having high risk of arrhythmia. Therapeutic drug monitoring is not required. Is it not required or required? TDM is always required with this class of drug, guys. Phenytoin enhances wound healing. I told you yes, and it is contraindicated absence seizure. Do remember, phenytoin is contraindicated in absence seizure and also contraindicated in myoclonic seizure. So there are a couple of drugs that are contraindicated in absence seizure, myoclonic seizure, because they can precipitate the scenario, they can worsen the scenario further on, right? Drugs like carbamazepine, oxcarbazepine, levetiracetam, all these drugs, or any other GABAergic drug, carbamazepine, oxcarbazepine, phenytoin, levetiracetam, or all other GABAergic drug, all other GABAergic drug, they can always and always precipitate absence seizure, because the firing frequency in absence seizure is already very less, that is 3 Hz per second. In myoclonic seizure it is 2 Hz per second. The firing frequency is already very less. If we give drug like this, they can precipitate the problem further. Okay. Next one. A patient pus culture is positive for Pseudomonas. Okay. Which of the following cephalosporin can be used? Now, the drug of choice for Pseudomonas, drug of choice in Pseudomonas, it is going to be none other than your ceftazidime, one of the third generation cephalosporin. We can use other drugs as well. Like for example, what are the other drugs that can be used apart from this? We can use fourth generation cephalosporin for Pseudomonas, like cefepime, cefpirone. Fifth generation cephalosporin is also shown to be effective, and it is also effective for MRSA. So cephalosporin that is effective for Ceph is cephalosporin. For MRSA, none of the cephalosporins are effective for MRSA except the one that is the fifth generation. So two questions we are trying to decode here. One is, what are the fifth generation? So fifth generation cephalosporin are ceftaroline, roll wale drug, ceftobiprole, ये भी रोल वाले ड्रग हैं, रोल एंड रोल. दे आर द फिफ्थ जनरेशन cephalosporin. They are effective for MRSA and they have also shown to have activity against Pseudomonas as well. Now, what are the other agents apart from do we have others? Yes, some of the beta lactams that are having activity against Pseudomonas like carbapenems. Yes, carbapenems. Extended spectrum beta lactams or extended spectrum penicillin. So, what are the extended spectrum penicillin that we know? Under the extended spectrum penicillin, we are having agents like carbenicillin, although it is obsolete now, carbenicillin, but it has activity against Pseudomonas, ticarcillin, meslocillin, azlocillin, right, piperacillin. All of them are having activity against Pseudomonas. What about the others? Your aminoglycosides also, they have activity against Pseudomonas. Aminoglycoside, they also can be used. Ciprofloxacin, it is also having activity against Pseudomonas. There are other drugs as well, like linezolid can also be effective against Pseudomonas. So, these are the important ones that are frequently utilized. But the drug of choice for Pseudomonas, it is going to be your ceftazidime is the drug of choice. It's the third generation cephalosporin. Okay. Cefixime, cephradine, cefotitan, they are not the preferred drug that can be used. They are, I mean, they are not effective against Pseudomonas. Another question examiner asked, which other drug is not effective? So, in that examination, I think that question was asked around 1617. Around 1617, that question was asked, which of the following antibiotic is not effective for Pseudomonas? The answer to that question was vancomycin, and you can check it out in the PYQ. Vancomycin, although it sounds like a very high grade of antibiotic, it is the drug of choice for MRSA, not effective in Pseudomonas. 60-year-old patient with type 2 diabetes mellitus, controlled on oral hypoglycemic agent. Which of the following shows maximum risk of hypoglycemia? Now, the one that does not have risk of hypoglycemia will be metformin. So, that is absolutely out. Acarbose, it is one of the alpha glucosidase inhibitor. Remember, it is also not associated with hypoglycemia. Pioglitazone, rosiglitazone, not much, but among the given one, there is one by the name of your insulin secretagogue. So, as the name itself is saying secretagogue, they are going to increase the insulin secretion. They will be increasing the insulin secretion, and any drug that is going to increase the insulin secretion or insulin itself, definitely it can cause hypoglycemia. I think it's pretty simple. So, glipizide, glyclazide, glibenclamide, they are all second generation sulfonylureas. They are all second generation sulfonylurea. They can cause side effect like hypoglycemia. This is the most common side effect. They can also cause weight gain because again insulin has fat sparing property. So, they are insulin secretagogue. Weight gain hoga. They can also lead to bone marrow suppression. An important side effect has been summarized here. So, glipizide definitely is a drug that will be causing hypoglycemia. Now, if you have to compare glipizide and insulin, which will be having more risk of hypoglycemia, definitely insulin will have more risk of hypoglycemia. तो जितने भी पेप्टाइड वाले ड्रग है ना, पेप्टाइड लाइक एक्जीनाटाइड, glipizide, glyburide, glibenclamide, they definitely will be associated with your hypoglycemia as a side effect. Alright. Next, a 48-year-old patient presented to OPD with tingling and numbness on the finger. The patient is chronic alcoholic and was recently started on anti-tubercular drug. What should be the treatment of this patient? So, anti-tubercular drug mein, what are we going to use? Isoniazid, rifampicin, pyrazinamide and ethambutol. Out of them, our drug isoniazid that we have, it is having two important property on vitamin B6, or we also call pyridoxine. One is it inhibit the activation of pyridoxine to pyridoxal phosphate. It inhibits the activation of pyridoxine to pyridoxal phosphate. This is one isoniazid. Apart from that, it also promote the vitamin B6 ka excretion. It promotes the vitamin B6 excretion. So, simply if the vitamin B6 excretion will be high, they are going to inhibit the activation of vitamin B6 to pyridoxal phosphate. There will be decrease in the pyridoxine and that can cause peripheral neuropathy. So, peripheral neuropathy is a very, very important side effect with the isoniazid. Peripheral neuropathy, psychosis, xerostomia, and because it's a drug that is metabolized by acetylation, they can also lead to lupus-like symptom, hepatotoxicity. These are the side effects that will be associated with your isoniazid specifically. So since it's mainly asking only about your peripheral neuropathy, the drug that is going to cause peripheral neuropathy here will be your vitamin B6, right? Again, we are just going short and crisp explanation here, but the detailed explanation of every drug in tuberculosis or every other important aspect of tuberculosis has been definitely discussed in our usual classes. Okay, next one. Now look at the image, and when you see the image, you always think about the gift. I used to call in the class a gift. So what is the gift here? A patient with a history of heartburn. He is taking some drug and he used to purchase some drug from a local pharmacy. Lately, he started to notice an increase in the size of the chest. So you can say increase in the size of chest, breast, whatever you want to say, as shown in the following image. Which drug is most likely to be implicated with the adverse effect? Guys, it's very simple. This is a case of gift of gynecomastia. Now, if the person is taking a drug for heartburn, that means possibly he is having gastroesophageal reflux, GERD. And GERD के लिए the drug of choice is what? PPI, proton pump inhibitor. But the good news is that proton pump inhibitor does not causes gynecomastia as a side effect. So which other drug? We are having H2 blocker like cimetidine. We are not using cimetidine because of the same reason. One is it is having anti-androgenic property. Because of the anti-androgenic property, they can lead to gift of gynecomastia, and also they are potent inhibitor of potent P450 inhibitor, and therefore drug interaction will be very, very high. Higher risk of drug interaction, so we are not preferring cimetidine. Rabeprazole is a potent PPI. It is not associated, which has not been reported to cause the gift of gynecomastia. Or ondansetron again 5-HT3 antagonist, they do not cause. Granisetron again from the same area. So they are the 5-HT3 antagonist. They are considered the drug of choice in nausea and vomiting, or also you can say drug of choice in chemo-induced nausea and vomiting. They can be used for the treatment and also for the prophylaxis. What are the other drugs that can cause? So next time examiner can give you that a patient is suffering from, let's say, arrhythmia. So which anti-arrhythmic drug can cause? Anti-arrhythmic drug. So you can say you are having anti-arrhythmic drug like amiodarone. Amiodarone is one such drug that can cause. So I'll just mention here few names. Other drugs that can cause the gift. So if they are going to ask anti-arrhythmic drugs, so you can say, sir, it will be most likely amiodarone. A drug was used for the treatment of heart failure or arrhythmia in heart failure. Now the patient is having gift of gynecomastia. Which drug? Possible drug will be digoxin. Digoxin is associated with your gift of gynecomastia. Anti-androgenic drugs like your spironolactone. One of the metabolites of spironolactone is canrenone and 7-alpha spironolactone. Canrenone and 7-alpha spironolactone, they are also anti-androgenic. Therefore, they can also cause gynecomastia. We are also having ketoconazole. They can also cause, and in addition to that, all the estrogenic drug or estrogenic containing compound and anti-androgenic drug. Estrogenic drug and anti-androgenic drug, they all can cause gift of gynecomastia. So quickly I have given you a list here that can cause gynecomastia. We are having amiodarone, we are having digoxin, spironolactone, ketoconazole, and estrogenic compound, and all the other anti-androgenic drug, they can also cause gift of gynecomastia. Okay. All right. Next one. A patient with thyroid disorder treated with a drug that directly result in the activation of nuclear receptor. Okay, so they are active on nuclear receptor. So what are the example of nuclear receptor? You know that, right? Retinoic acid, vitamin A, and thyroxine, and altered gene expression. Which of the following was most likely drug? So anyone that is acting through the nuclear receptor, they will definitely act through gene transcription or nuclear transcription. Nuclear transcription is a very, very important feature with the drugs acting through the nuclear receptor. That is why all the drugs acting through the nuclear receptor, they are the slowest acting. They are the slowest acting because nuclear transcription definitely takes some time. So among the given one, let's read one by one. Which of the following is the most likely drug that is associated with the nuclear receptor activity and altering the gene activation? Now, what is propylthiouracil? It's an anti-thyroid drug. It's a thyroid peroxidase inhibitor. That is question number 1. And propylthyracil, it is also going to inhibit peripheral T4 to T3 conversion. Potassium iodide, it is known as a thyroid constipating agent. So prior to the surgery, we are going to use glucose, iodine, potassium iodide. They are the fastest acting drug and they are going to shrink down the size. So they inhibit the thyroid hormone secretion in the circulation. We call them as a thyroid constipating agent. We call them thyroid constipating agent. Methimazole is also one of the thyroid peroxidase inhibitor. It's an enzyme inhibitor. Look at levothyroxine, the T3, T4, they are the one that is acting through the nuclear receptor. So through nuclear receptor, we are having many, right? Let's say, we have retinoic acid receptor. We are having retinoic acid receptor, estrogens, retinoic acid receptor, estrogen, vitamin A. Not only that, we are also having PPAR, peroxisome proliferator activator receptor, alpha, gamma. Then we also have aryl hydrocarbon receptor. Aryl hydrocarbon receptor. See, aryl hydrocarbon proton pump inhibitor acts through aryl hydrocarbon receptor. PPAR alpha, alpha, Fa, Phi, fibrates. So drug that will be acting through PPAR alpha will be all the fibrates, and they are going to increase the activity of lipoprotein lipase. After nuclear transcription, they will be increasing the lipoprotein lipase that will be causing breakdown of triglyceride. PPAR gamma drugs like your pioglitazone. So you can see it's very, very easy to remember. Fa, fibrate, gamma, glucose, glitazone, aryl hydrocarbon receptor, PPI are going to act through this, and they are the example of agents that is acting through the nuclear receptor. So remember, under nuclear receptor we have a lot. Under nuclear receptor we are having vitamin D also. All the steroids, they are also acting through the nuclear receptor. All the steroids, they also act through nuclear receptor, but the problem is this nuclear receptor are actually present in the cytoplasm. The broad name is nuclear receptor. Some of these nuclear receptors are present in the nucleus itself. Some of these nuclear receptors are present in the cytoplasm. They are all collectively known as your nuclear receptor only. All the steroids, vitamin D, everything. They are all coming under nuclear receptor superfamily as well, including the sex steroid. But there is one sex steroid that I have written here, like let's say estrogen is one of the sex steroid. Their main location is in the nucleus itself, but they are all nuclear receptor. Okay. 32-year-old cancer patient with a history of heavy smoking is experiencing decrease in the pulmonary function. Physical examination and chest X-ray indicate presence of pre-existing lung disease. Okay, so there is already decrease in the pulmonary function and there is a pre-existing lung disease. Which drug should be avoided? So any drug that is further can cause pulmonary function test deterioration will be avoided. So among the given one, the drug that should be avoided will be bleomycin. So what are the drugs that is associated with the pulmonary toxicity? So we have drugs like your bleomycin. We have drug that is your busulfan. We have drug like your cyclophosphamide. We have drug like your methotrexate. We also have drug like your amiodarone that can cause pulmonary fibrosis. Methisargide, and there were few other agents that were used earlier like gold salts. They were also associated with pulmonary fibrosis. Now in the recent examination, examiner didn't ask which drug is causing pulmonary fibrosis. Examiner actually asked that if a drug is causing pulmonary fibrosis, for the prevention what are you going to do? So for the prevention we are going to use perfenidone. So this was in 2022 exam question. Perfenidone is given, it slows down the progression of pulmonary fibrosis. So for the prevention of pulmonary fibrosis, pulmonary fibrosis का prevention के लिए, like we are going to give IV mesna for the prevention of hemorrhagic cystitis, we can also use perfenidone. Okay, correct answer to this question is none other than bleomycin. Cisplatin will be causing ototoxicity, nephrotoxicity. It can also cause other side effect like peripheral neuropathy. Vincristine also will be causing peripheral neuropathy. Doxorubicin will be mainly causing your cardiotoxicity. It's a highly cardiotoxic agent. Cisplatin will be causing ototoxicity, nephrotoxic agent. So I have quickly summarized other options as well. Okay. So this was the last question that we had in our GT today. I hope all of you guys have got most of the questions correct. If there is any doubt, anything you could not understand, definitely you can just ping me. And in addition to that, remember, this was just a quick revision of the questions, but the detailed explanation about each of this topic we have discussed in our usual classes. So go ahead, check it out. If there is any point that you could not understand, feel free to reach out to us. Thank you very much to all of you. All the very best.